Yeah, good afternoon, everyone. For the 8th online STG lecture series, where we have the today's topic on prescribing safety with special to pregnancy and lactation by Dr. Sangeeta Sharma and Burns Care Clinical Practice Guidelines by Dr. Arun Goyal. I welcome all the participants and the panelists and also the resource person of this today's subject. And I request Dr. Jain Srivatsava Sir, Advisor, QPS Division, to welcome the Dr. Arun Goyal by presenting a plant. Please, sir.
It is my privilege. Welcome.
Thank you, sir. And also I request Dr. Jain Srivatsava Sir to address the participants and brief about the STG online lecture series. Over to you, sir.
Thank you, Annapurna, and a very good afternoon to my, esteemed partner, Delhi Society for Promotion of Rational Use of Drugs, led by Professor Sangeeta Sharma. And you can see on my right, we are privileged to have with us physically, just to add on, Dr. Arun Goyal, who took all the efforts to come over here in this Saturday afternoon to talk to us on this. And it is my proud privilege to introduce him. We were just talking that all throughout, he has been leading the efforts at LNJP Hospital for providing the rational and utmost care which a country can, which the India can afford for the burn victims in particular, and a very eminent plastic surgeon. And I just came to know that his daughter has also followed the father's footsteps to be plastic surgeon. She is a qualified plastic surgeon, and my best wishes to her. And in his illustrious career, without going into much ado, we know that in place like Delhi, where all the cases of the burns, they come from all over the country, besides the neighboring states, the patients are flown. Because I belong to UP, I know the ground realities. And he has been, in fact, leading the efforts, besides academic pursuit, like being the examiner of the post-PG, that is MCH course in plastic and burn surgery. And just to update him and to the participants who are joining for first time, that we know that Indian public health system is very much tiered system, that in the most peripheral unit, we have got the sub-centers, where it is our endeavor that during last 2 to 3 years, that the community as a large receives some kind of first aid, some kind of primary care. Keeping the limitations and availability of qualified doctors at appropriate level, the decision was taken that there will be a nurse practitioner over there who will, within the boundary walls, who will render the first aid, so that at least any person who is in the need of this care gets the care within half an hour. The primary care availability need to be there for half an hour. And similarly, like we have got the primary health centers, where technically as per Indian Public Health Standard guidelines, there is a requirement that at least 2 doctors should be there, but practically it never happens. And in most of the places, there is a single doctor. So it becomes for us to appreciate that these people are working in a very resource constrained setting, where all of us sitting in the tertiary care would desire that when the case comes, because they are responsible to provide the first aid, they are responsible to provide the initial care, they are also responsible to ensure that the stabilization of the patient happens. And in that context, lot of harms also takes place, which all of us are too aware. Then we have got the community health center, where there is requirement that having at least 3-4 basic specialties being there. At least a surgeon should be there, but practically in the country, in very few states, the people are available, and district hospitals. And towards this, strengthening this health system for a common person, common people, the government has spent a lot of money. A lot of investments have gone into. But when we are talking about strengthening the health system, it should also result into the commensurate better health outcomes. Unfortunately, that has not happened. For a variety of reasons, it is not having the enabling conditions, not having the adequate HR or human resources. Even if the adequate HR is available, they don't have the requisite knowledge, skill, and inherent confidence to practice the art and science knowledge which we all get taught in the various course of our career, education, and training programs. So the poor quality of care is rampant across. I'm not talking about merely the certification part. It is as such talking about the general practices which a person can do, person is capable of doing, but does not practice for a variety of reasons. And to strengthen these efforts, in fact, NHSRC is so for your information, it is a technical support organization for the Ministry of the Health and the state governments to support primarily for strengthening the health system as such. And not only the government, because we also realize that lot of care, whether it is the OPD or IPD care, gets provided in the non-government sector as well. And it is not that, there are issues, there are challenges in those setups also. So to address these challenges in a very small way, National Health System Resource Center, today in fact our executive director has traveled to Manipal. Otherwise he would have also joined us over here. This institution has been created, and in partnership with Delhi Society for Promotion of Rational Use of Drug, we have been running this series on every third Saturday of the month, where we basically cover two aspects. One is pertaining to the rational prescribing, rational use of the drugs, antimicrobial resistance, medication safety, and why that uses of the standard treatment guidelines, protocols is important. That largely gets covered by Professor Sangeeta Sharma, who is a well-known figure in the country. And to touch upon the clinical domain, we always invite an eminent expert to speak to our people who are in the periphery, in the districts, and many professional association members have also joined today. And till date, in fact, we started with the first lecture in the month of September 2022, when Padma Shri Dr. Bavaskar spoke on the snake bite. And since then, till date, we have covered the 7 topics: snake bite, hypertension, diabetes, COPD, epilepsy, dog bite, and foreign body in the ear, nose, throat. So these had been the broad topics covered. And you would appreciate that tertiary care settings are different, but the primary and secondary cares are different. So while our humble request to you would be, while you touch upon that aspect, but what in the periphery they should be doing and they should not be doing, more importantly, at least for the burn victims, because we all know, I'm not going to touch upon too much of the statistics, but it remains a problem and it leaves lifelong, all of us are too aware, lifelong disabilities. So without much ado, I'm going to stop over here. But again, we are extremely grateful and privileged to have you over here. And also a big thanks to Dr. Sangeeta Sharma and all her efforts, because yesterday also Madam was engaged in the another program on the diagnostic stewardship. So she has taken a mission that how the prescribing habits could also be, it could be improved upon, because we are looking at real improved care which gets delivered to every level of beneficiaries. So with these many words, thank you once again. Thank you very much for being with us. And Madam, all yours.
Thank you, sir, for your kind introduction and setting the scene for the series and today's topic. I think you will all appreciate this is an effort, joint effort with the NHSRC and DSPRUD, that we are trying to reach out to the far-flung areas of the country. Otherwise, many of you may not have access to continuing medical education, but this is our endeavor so that we can reach out to you. Technology has come to our rescue. We can connect with you all at one time from all over India. At your convenience of home or office space, you don't have to travel. So I think COVID-19 pandemic that way was a blessing more than a disguise in this aspect. Don't quote me wrong, for this, because otherwise we would not have leveraged technology for this kind of effort. I'm very thankful to NHSRC and all of you who come every third Saturday here and like to spend this time with us. Do I need an introduction, Annapurna? I can skip that.
Annapurna is
Yeah.
very good.
Because
I think I can skip that.
Participants are there, hope so, because the participants are
Okay.
Okay, thank you, sir, for giving the brief introduction about the STG lecture series, which we have started from the September to 2022, and for setting up the dais for the next resource persons. Now I welcome Dr. Sangeeta Sharma, Professor, Institute of Human Behavior and Allied Sciences, as a President of DSPRUD. She has conducted more than 200 trainings in her career, and she's a very rich and diversified professional and managerial experience in health. When it comes to her drugs, she has a pioneer in the introducing the standard treatment guidelines manual, which tells about medical therapeutics. And I welcome you, ma'am, with the brief discussion about the pre-test, and we can move to the session from prescribing safety with special to pregnancy and lactation.
Sure.
Over to you, ma'am.
Thank you, Annapurna, for that. Can I? Okay. I will, have attempted the pre-test. We will discuss at the end of the session, because I think you will get, it will save on time, and also you will get the answers when you attend the session. And when we can, at the end of the session, we can discuss that. Okay. Now, today I'm to talk about prescribing safely pregnancy medication and what is the role of standard treatment guidelines. I think all would agree. You can see my screen. I hope you can see my screen.
Yes, ma'am.
Okay, it is in the full slideshow. Okay, now there is a dictum: if it is not safe, it is not care. Recently at 2023 Global Ministerial Summit on Patient Safety, 87 national ministers of health gathered to discuss the systems level approaches to improving patient safety, and they focus on actions for all countries to take, including treating patient safety as a global public health priority. So that's the kind of importance that we have. We need providing care is not enough, but we need to see that the care that we provide is safe as well. Now, all of you must be aware of this thalidomide incident which took place in 1950s. Phocomelia was caused by thalidomide. This thalidomide was given as a sedative to pregnant women, and between 1950 to 1960s, almost 10,000 to 20,000 children in 46 countries were born with deformities such as phocomelia. So you can see the picture itself is very horrifying. So, but this incident led to a public outcry to the institution all around the world for drug regulatory authorities to be more careful, to follow a sophisticated approach to the preclinical testing and clinical evaluation of drugs before marketing, and especially when these drugs are being given to the pregnant women, because it can affect the fetal development, can lead to many defects. These needs to be seen carefully. Now, what are the issues around drugs in pregnancy? Some medication, definitely we know that they are harmful when taken during pregnancy, but others are unlikely to cause harm, so we need to know. And also, this is a fact that only half of all pregnancies are planned. The patient may be having some other illness, taking medicines for that, and then the woman gets to know that they are pregnant. So half of the time they do not know whether they are pregnant, and they may unknowingly, unsuspectedly, may be consuming a medicine which can have a harmful effect on the fetus. Now, also, many women need medications for pregnancy induced conditions like morning sickness, chronic conditions like they may be already having epilepsy, diabetes, hypertension, or sometime some intercurrent illness, allergies, or something else comes up, some other infection comes up during pregnancy. So what do we do? Do we stop all these medicines, just because they are pregnant? We'll be talking about it, because stopping of some medicines although can be stopped, but there are harms associated if you stop these medicines, particularly if the woman is epileptic. It may One single seizure can cause harm to the fetus. So each seizure brings harm to the mother as well as to the fetus. So can we stop? So we cannot stop this. The answer is clearly no, that you cannot stop. But then because of the pregnancy, there are a lot of physiological changes also take place in the mother's body. So this might affect the pharmacokinetics, the dose required for treating. The earlier dose that the patient was taking may have been adequate for that patient, but during pregnancy you may have to increase the dose to reach the same level. So there are several such issues involved with the use of medicines in pregnancy. Then also there is another category of women who work with chemicals. In factories, they are exposed to radiation and may also use illicit drugs. This may also affect embryogenesis, and adversely affect the development. The frequently used teratogenics, sometimes we may not even appreciate that they may cause harm to the baby. Alcohol use, chronic and heavy use of alcohol is associated with fetal alcohol syndrome, where craniofacial skeletal abnormalities happen, growth retardation can be there, and mental disorders can be seen in the baby. Smoking, again, there are a lot of birth defects that can happen because of the smoking. Orofacial clefts, lower birth weight, premature birth, placenta previa, abruptio, and sudden infant death syndrome. You may be saying, women do not indulge this, but I think do not underestimate this illicit use or social use of these drugs. It is quite common. They may not declare it, but it is quite common. So you need to really explore that, what is the consumption level. While any use of alcohol or smoking is harmful, but particularly chronic and heavy use would be detrimental here. Similarly, coffee, we may not even be considering this as a drug here, but again, this is a social medicine that we all take. So again, consumption of coffee also needs to be limited, because if there is a more than 300 milligram of caffeine consumption per day, which means more than 3 to 6 cups of coffee, it can lead to increased risk of fetal death. So limitation on coffee also should be seen. Similarly, vitamin A can be an teratogenic here. So of course, other illicit drugs such as cocaine, opioid, these all should be avoided. They are associated with a lot of complications and serious problems in developing fetus. Now, how does this affect drug use in pregnancy? It could be the effect of toxic drugs, that already that they have a detrimental effect on the organogenesis. It can lead to malformation, growth retardation, sudden fetal death, functional defects in the newborn, and also premature birth. So generally, the dictum is that use drugs with caution during pregnancy. But as I said earlier, not all use of drugs in pregnancy is always wrong. The dictum is that use as less or no medicine as far as possible, but if required for some comorbid pathology or disease, you have to weigh the benefits versus risk here. So in that context, you say that use of drugs in pregnancy is not always wrong. And for example, like high fever, if you don't treat high fever, this could be harmful to the fetus in the first months. So use of paracetamol would be better than no treatment being given here. Similarly, diabetes during pregnancy, they need intensive therapy with insulin. Otherwise, it will have a bad impact on the baby's development. Folic acid protects against the spina benefit neural tube defects. So that is why it is part of the national programs that you supplement folic acid for all women, and especially if the pregnancy is planned one, you start this folic acid 3 months prior to conception, so that and especially you need to give higher dose of folic acid to those women who had a history of neural tube defects. So most of the anti-epileptics are teratogenic, but an epileptic insult may provoke harmful anoxia for the fetus. So it's very important that we need to treat these patients. Now, how does this harm? How can these medicines affect the fetus? The first mechanism is by having the direct effect on the fetus, leading to abnormal development. This includes birth defects and death. Suddenly you don't know, abortion happens or a stillbirth happens. This could be because of the direct effect of the medicine on the fetus. Then these medicines can impact or affect constriction of placental blood vessels. Thus, these may reduce the supply of oxygen and nutrients to the fetus from the mother, resulting in underweight and underdeveloped baby. Then, forceful contraction of uterine muscles indirectly injures the fetus by reducing their blood supply or triggering preterm labor and delivery in these patients. Lowering maternal blood pressure may also indirectly reduce blood flow to the placenta and staggering supply of oxygen and nutrients to the fetus. Now, factors which affect the safe use of medicine in pregnancies, we must consider the stage of the pregnancy, what stage it is, first trimester, second, third trimester, the type of medicine it is, the risk category. When we say the type of medicine, we mean risk category of the medicine. FDA has defined various drugs into different categories depending on the safety profile of the drug and the dose of the medicine, the frequency of medicine use, and the health of the mother. So all of these can affect. Now there are, for example, although pregnancy is a physiological process, but as I told you, there are four main mechanisms by which these medicines can impact the fetal growth and development. So let us see what happens at various stages of pregnancy. Less than 4 weeks, this is the period of blastogenesis. So there is no blood supply connecting mother and fetus. Fetal organs have not yet started to form. So the medicine, if you use medicines during this time, it may act in an all or nothing fashion. When I say all or none fashion, means either nothing may happen to the baby. The drug use may pass off safely here, but it may result in killing the fetus, or you will find that the abortion takes place. Then 4 to 9 weeks is the period of organogenesis. All major organs start developing during this period, and this is the most highly vulnerable time for birth defects. So particularly be careful of medicine use during this time of pregnancy. Uh, Different organs may form at different specific time points. For example, limb birds, arms and legs develop at week 6, while the heart divides into different cavities at week 7. So, because of the medicine use or because of the harmful impact of the medicine, miscarriage may happen, or an obvious birth defect may be seen. Permanent effect may not be noticed immediately, but it may be noticed later depending on the exposure and the timing of the target organ being formed. Now, between 9 to 13 weeks, uh, this is the time when embryo is referred to as a fetus. So development during this time is primarily maturation and growth of these organs. So the fetal organs require nutrition to grow and begin to function. So while nothing much harmful major congenital malformation is expected at this time, but growth and function of these may be altered because of the use of the medicines. 13 to 26 weeks of fetal organs require nutrition to grow and begin to function, so they have minimal effect on the fetus development. Third trimester is 27 to 40 weeks, but although the development is taking place, fetal organs are immature and they are less efficient at nutrient and medication elimination than the mother. So there is a chance that the levels of the medication would increase in the fetal blood circulation, and it can cause toxicity, and in some cases withdrawal effect during postpartum period may be seen. So 3 to 9 months there are less risk of malformation except for urogenital tract, CNS, but during this time expect more functional effect, such as if you use aminoglycosides, nephrotoxicity or ototoxicity may happen. Then salicylate may increase the risk. Okay, having said that, what happens during the physiology and how the medicines can impact at various stages of pregnancy. Now let's come to the type of the drug that we give. Although no drug is proven free from teratogenic effect, however, some medicines have a lower risk than others. So FDA, Food Drug Authority, US, they have categorized drugs into different risk classification, from category A, B, C, D, and X. So the generally the category A is considered as the safest, as you have evidence of safety of use of a medicine in human beings, whereas category X is the most harmful. There is a no danger. So category X medicines should not be used. You can get these details, if you are looking, you want to use medicine for a particular, you can go to these sites and look at this. Quickly, let me just explain what is category A. These are well studied and are considered safe during pregnancy. For example, vitamins, folic acid, levothyroxine, these are safe medicines. You can use them. Category B, they have been studied in animals but not in pregnant women, and but they have been used in pregnant women but have not shown any risk to the fetus. Here comes the paracetamol, acetaminophen, amoxicillin, ondansetron, metoclopramide, cephalosporins, metronidazole, etc. These are all category B drugs. Category C are that they have shown adverse effects in animals. You don't have much data in humans here. So most of these, drugs, if you find, they are category C. I have given examples here so that, because mother and child health is the main focus. Largely all the programs and all the district level, secondary level healthcare facility, mother and child is the main focus. So I think this should be useful, because the knowledge. Category D is that here they have been shown to have adverse effects in human studies, but the potential benefit may outweigh the risk in certain situations, like aspirin use in third trimester, the paroxetine, phenytoin, ACE inhibitors, ARBs. Generally these should not be used in pregnancy, but in the special situations, when the benefit you think would outweigh the risk, then only these category D medicines should be used. And category X is do not use category, do not at all, because they have shown clear evidence of fetal harm. So it should not be used. This includes, of course, thalidomide, vitamin A derivatives, isotretinoin, warfarin, ergometrin, danazol, these hormones, dutasteroid, methotrexate, etc. Although methotrexate is all used now for, but here you again need to weigh the benefit versus risk here. So there are other drugs which are which are strictly contraindicated. These includes category X and D category. So these statins, anticoagulants, warfarin, anti-cancer drugs, morphine, tramadol. Morphine during labor can lead to fetal asphyxia, and tramadol also can has led to respiratory depression and addiction. These hormones, benzodiazepine use, again, this is a category D drug. in late pregnancy. It can lead to slow breathing, withdrawal syndrome in the newborn, and in high doses, it may cause floppy infant syndrome, respiratory distress syndrome. So only to be used if benefits outweigh the risk. Now, coming to the anti-epileptic drugs, which you may see there is epilepsy. A lot of people have epilepsy. These women get married and they get pregnant also. So carbamazepine, phenytoin, fosphenytoin, phenobarbital. These are all category sodium valproate. These are all category D anti-epileptic drugs. They have been shown to have uh, congenital defects and can also developmental delay, mild retardation. All these drugs should be only given if risk benefits are more than the risks involved. Similarly, the mood stabilizers, many of the bipolar affective disorder, where the patient may have cycles of depression and mania. This is called BPAD, bipolar affective disorder. So these patients also may require ongoing treatment, but lithium is not recommended. Another drug which is used as a mood stabilizer is valproic acid, but again, sodium valproate is shown to have a lot of birth defects, cleft palate, and other abnormalities. So these two group of drugs should not be used. Antidepressants, citalopram, escitalopram, fluoxetine, paroxetine, sertraline. These again, depression is also quite common and it may worsen during pregnancy, but these are category D drugs. So especially look at use in the first trimester if you can avoid these. Now coming to aspirin and other salicylates, this is again a category D. Especially if given in third trimester, it can delay start of labor and lead to premature closing of ductus arteriosus or primary pulmonary hypertension, jaundice, and all that. So, an overdose can lead to liver toxicity in both fetus and the mother. ACE inhibitors, again, these are contraindicated drugs because if given in second or third trimester may cause kidney damage in the fetus. Now the question comes, this is important, but because the women may have pre-existing hypertension or may develop hypertension during pregnancy, ACE inhibitors are not a good choice here for treatment of these conditions. Similarly, anti-thyroid drugs are not advocated, are contraindicated, but if at all you have to use propyl uracil can be used as it has been found to be safe. Then aminoglycosides generally again are category D. It can lead to nephrotoxicity and fetal ototoxicity. If you now here are certain in this column I have got drugs which are relatively, I'm using this word relatively safe because there is nothing like absolute safe when it comes to pregnancy, but relatively safe or questionable safety. You may have to use these drugs, but then be careful, watch the mother and the child closely, and see the appropriate treatment for the shortest duration is given. Chlorpheniramine, promethazine are relatively safe, whereas the cetirizine, fexofenadine, loratadine, first trimester, they can lead to spontaneous abortion, ectopic kidney, and undescended testes. NSAID, paracetamol, and ibuprofen in low doses are okay because the women may have pain. We need these drugs for fever and pain. Paracetamol is safe, and ibuprofen should be used in low dose. High dose can be harmful for the child. So all other NSAIDs are not preferred during pregnancy. You may have to prescribe decongestants, as the mother may have some flu, common cold. So topical are always preferred here. You can use medicated nasal drops, but don't use combination decongestants containing alcohol or guanfacine, codeine. These should not be used because there are chances that it can lead to adverse drug effects. The may have asthma. You may need to use bronchodilators here. Again, inhalational therapy is preferred because this will be directly delivered at the site of action, and the dose required is in micrograms, so it's a very small dose. Oral should be avoided. Systemic treatment should be avoided because these medicines are category C medicines. Then similarly, steroids, go for inhalational steroids, low dose, low potency topical corticosteroids. If at all you have to use, prednisolone should be used with caution. Oral or systemic therapy with steroid, there is a chance risk of cleft lip, low birth weight, preeclampsia, and preterm birth. The pregnant women may need these for acidity. Acidity is a common problem. You can use ranitidine, famotidine, omeprazole, pantoprazole for these, but generally antacid are preferred, but if required, this can be used. These are all category B drugs, so need caution here. For diarrhea, ORS is the mainstay, just like in any other adult. In pregnancy also, ORS is the safest here, but antidiarrheals are category C, so should not be using the antidiarrheals. Constipation is another common problem in women, pregnant women. Again, fiber containing these isgula and lactulose, milk of magnesia with high fiber diet is the recommended treatment. Do not use osmotic laxatives, as it may cause problems in not only in the mother, but it can affect the fetus on prolonged use. Vomiting is another common first trimester problem. Doxylamine, meclizine, dicyclomine, promethazine, prochlorperazine, these can be used, but ondansetron, when taken during first trimester, there is a possible risk of congenital heart disease. For thyroid problems, thyroxine can be used, but it can lead to problems in the baby. Propyl thyroid is safe, but do not use methimazole or carbimazole in hyperthyroid patients. Folic acid, yes, you can use it. It is recommended in the programs also. A higher dose is recommended in India. In fact, if pregnancy is planned, it is said it can be started 3 months before conception, or at least start from the first trimester till term it is given. And oral iron salts or the parenteral ones can be given in the second trimester. Iron is started usually in the second trimester because iron itself can lead to nausea, vomiting in the first trimester. Then coming to heparins, are safe, but warfarin should not be used, especially in the first trimester, because it can lead to fetal warfarin syndrome. Used during second and third trimester is associated with increased risk of fetal formation. Now, coming to diabetes, gestational diabetes is an important problem. The diabetes may also pre-exist. The drug of choice, safest drug is insulin for both type 2 diabetes and the gestational diabetes. Oral hypoglycemic agents, these are category B and C drugs. So insulin is preferred here. I think I already covered anti-epileptic drugs. Carbamazepine and valproate both should be used with caution. Lithium is unsafe. The newer anti-epileptic drugs, felvamate, gabapentin, levetiracetam, these are can be used, but then you have to weigh the risk versus benefit here. They have a better safety profile than carbamazepine and valproate and other anticonvulsants. Now, coming to antipsychotics, psychosis can, the mother who is psychotic, they get pregnant, and but if you stop treatment, it is not necessarily that the schizophrenia or psychosis is more prevalent in pregnant, but already they are having this problem. But if you stop their treatment, they can go into acute exacerbation, and they become agitated or aggressive. So treatment may become difficult. These You don't have to stop these antipsychotics. You continue using these haloperidol, trifluperazine, risperidone, olanzapine. These can be used safely, but with you need to monitor the mother as well as the newborn at birth, as the passage of the drug stops from mother through the placenta. So there could be some problem. Similarly, then antidepressants, you need to continue these medicines, imipramine, amitriptyline. The newer ones, the fluoxetine, venlafaxine, can lead to low birth weight babies, preterm babies. So again, you need to weigh the benefit versus risk here. Antihypertensive drugs, all of them are category B drugs, but methyl dopa, hydralazine, atenolol, metoprolol, prazosin, nifedipine can be used in hypertension, but certainly ACE inhibitors and calcium channel blockers, you need to exercise caution here, especially with the ACE inhibitors. Second or third trimester may cause kidney damage in the fetus and decrease the amount of amniotic fluid and lead to deformities of face, limb, and lung. Again, calcium channel blockers in first trimester may cause birth defects. Thiazide diuretics, they decrease the oxygen, sodium, and potassium levels and number of platelets in the fetus blood, and can lead to slow down the growth of the fetus. So they have adverse drug effects are known with this. Now, next category of the drug which can be used in pregnancy, because these pregnant women can also become suffer from an incurable disease, so you need to treat them. So penicillins and cephalosporins are the safest group here. So go for these. If at all you have to use antibiotics in pregnant women. Nitrofurantoin, macrolides, fluoroquinolones, sulfonamides, tetracyclines, chloramphenicol, these are all category C drugs. So only should be used when the benefit outweighs the risk. Otherwise, go for penicillins and cephalosporins here. Now, coming to antiviral agents, which can be used, acyclovir and valacyclovir can be used, but rest are all category B drugs. Coming to anti-tubercular drugs, rifampicin, isoniazid, and ethambutol can be used. Pyrazinamide is the most teratogenic here. It belongs to category D, C, and D category. Aminoglycosides should not be used, and similarly, fluoroquinolones are category C drugs. Should not use as part of the ATT for the treatment of tuberculosis. Now, coming to malaria, quinine can be used in first trimester only with caution. chloroquine, proguanil, sulfadoxine. These are all category C drugs. Just a minute. Just give me a minute. Hello. अरे मैं लेक्चर ले रही हूँ आप पासवर्ड कर just a minute. Okay, then chlortriamoxazole and antifungal agents. You can use clotrimazole, nicotine, fluconazole, but with caution. Again, topical therapy should be preferred here. Fluconazole, since it is given as a single dose, perhaps there is no increased risk of birth defects. You can use it, but fluconazole in high doses can lead to problems, birth defects, so it should be avoided. The HIV medicines, all of them are Jedovudine, Nevirapine, these can be used, but these are category C drugs. Now, okay, I think I have mentioned about a lot of categories of medicine in some time or the other in pregnancy, but generally the most commonly used medicines are acetaminophen, paracetamol, and low dose ibuprofen for pain relief. Prenatal vitamins can be used for proper nutrition. Iron supplements can be used to prevent anemia, and some antibiotics, penicillins and cephalosporins only. Rest all should be avoided. Antacids are preferred for acidity problem. Now, the basic, if I need to summarize this, withdraw all unnecessary medications 3 to 6 months before conception. Those who are at risk of conceiving or who wish to become pregnant. So no necessary medication, just in case may be having, or you may be using it otherwise in adults, but the same rule does not apply here. Remove all unnecessary medications. Go for non-pharmacological measures as far as possible. For example, if it is acidity, the posture, the timing of meals, you try, fixing up that first. If still the problems persist, then only you go on for using the medicines for that. And medicines to be prescribed only in case of compelling indications. Advise patient not to take any OTC medication without consultation. Always assess benefit versus risk, and the choice of the drug. I told you, do look at which category of the risk classification it belongs. Category A, perhaps you can safely use. Category X is absolutely contraindicated in pregnancy. So especially when look at the medicines which are to be best avoided in the first trimester. And whenever you need, if you think that the benefit has outweighed the risk, use it in small duration, small dose, and for a smaller duration. Now, coming to the vaccines during pregnancy, that's again, there are certain vaccines which are recommended, and certain vaccines which are kept in a reserve, and some vaccines which are not recommended. Of course, the program says Tdap vaccine, influenza vaccine, it is recommended in the second or third trimester, and Tdap is recommended during third trimester. Reserved, these are medicines reserved depending on the situation. If they are at increased risk of exposure to these infections. Perhaps you can administer these vaccines, but again, you need to weigh, whether these needs to be given during pregnancy or not. Live attenuated vaccines are usually not recommended because, for example, rubella or varicella, because there is a potential risk that the fetus, it will pass through the placenta, and there is a risk to the fetus. The fetus may get this infection. So risk is highest between 13 to 22 weeks. So the next, after the pregnancy, the next is the what are the drugs which can be used during delivery. Again, same principles apply, but you need to give, there is a, you want to relieve pain, manage complications, and assist in delivery process. And you need to bear in mind that the drugs may have effect on the newborns. You commonly use oxytocin, prostaglandin, misoprostol during delivery. Antibiotics may be required, magnesium sulfate, oxytocin, betamethasone. These are required in women who are at risk of preterm delivery. But these betamethasone is best used, the most use utility is when it is administered at least 24 hours in advance. But sometime, or up to 7 days from the, uh, but it is not effective after 7 days, so the many times I have seen people using it, the mother has come late, so betamethasone has to be given. So even if there is less than 24 hours, you expect that the delivery will happen. Many people give it, even if there are 6 hours there, they give it. But remember that the efficacy of this antenatal steroid would be reduced. Best is to give at before 24 hours of delivery. Now there are many pain relievers that are used, many pregnancy for painless pregnant delivery. Epidural anesthesia is given, nitroxide is given, fentanyl and morphine are given. But avoid serious depressants because it can lead to floppy infant syndrome. Avoid drugs which can increase bleeding risk, like anticoagulant, aspirin, and then NSAIDs and salicylates. They decline uterine contractility as well. So be careful. Then last part is, the lactation. There are medicines. If there is a question whether the medicines being taken by the mother, whether they can affect the baby, newborn baby as well. So although you cannot make out how much is transferred from mother to the breast milk, but there are drugs which can cross this barrier and are secreted in the milk. And there are a lot of pharmacokinetic factors such as protein binding, lipid stability, ionization. These can affect this. Uh, Nearly, if you have to say this in general, nearly all drugs transfer into breast milk to some extent, except for heparin and insulin, which are too large to cross this biological membrane. So the infant almost invariably receives no benefit from this form of exposure. Transfer is greatest in the presence of low maternal plasma protein binding and high solubility. So, and milk is slightly more acidic than plasma, so allowing weak basic drugs to transfer more readily into the breast milk. Now, let me translate this into how does it affect the infant. The infants have limited GFR and creatinine clearance, so it is approximately 1/3 in comparison to adults. So even a small amount of drug in the breast milk can lead to accumulation of these drugs and toxicity in the infant. The hepatic metabolism is also impaired in neonates. So there are drugs, if which are under first pass metabolism, they have higher oral bioavailability, resulting in accumulation and toxicity. So decision to whether to breastfeed while mother is on drug therapy is done by overall assessment of benefits and risk. So again, the dictum here is that you choose the lowest effective dose, minimize the exposure, use short acting medicines as far as possible, do not use long acting medicines, and then if possible select an alternative route or a product which is safer, which has minimal systemic exposure to the mother. For example, if you have to, for constipation, choose high fiber diet or fiber laxative over a stimulant laxative here. If at all, again, like in pregnancy, sometimes you may not be able to stop these medicines in the mother, those are required. So there are three things that you can do. Either you suspend the breastfeeding for drugs which have known potential toxicity, such as if the mother needs cytotoxic drugs or there are radio contrast media, etc. Or if mother needs a drug which has a prolonged toxic therapy, in such case you can switch to by bottle feeding or alternating breast and the bottle feeding here. And then also, for most of the drugs you can adjust the time of drug intake versus breastfeeding. Breastfeed before next scheduled dose to minimize the drug concentration to the lowest. Will have minimal exposure of the baby on this. Now, okay, this is over the drug use in pregnancy. Now let's come to how standard treatment guidelines can help you treating mothers safely during the standard treatment guidelines usually would mention which drug can be given safely. Usually they have a section for drug treatment, and as you know, the main key feature of the standard treatment guideline is that it targets prior conditions. It's not a textbook of medicine or a pharmacology or pediatrics, but it includes target priority conditions. You need to coordinate with the special programs, use peers, and use this. Yes, Anpurna. Hello. Yes, Anpurna.
Discussion is also muted.
Huh? Okay, so I'll be just 4 or 5 slides left. I think yes, the standard treatment guidelines usually help you because these are concise, where the recommendations for treatment or not to treat, whether to treat with the non-pharmacological treatment or with a pharmacological drug, which drugs are can be used, what are the adverse effect that you may see, what is the maximum dose. Standard treatment guidelines describe all these pharmacological treatment in detail. Plus these standard treatment guidelines tell you the stepwise treatment, as the patient presents, whether the non-pharmacological would be tried first, and when would you institute pharmacological treatment, then which one would be added if the patient is not responding. So like that, pharmacological treatment is given. And let me tell you, don't confuse between step up therapy with the combination therapy. Very often I find that this is quite well known. As the disease progresses, you may have to step up therapy, you may have to add other drugs for the treatment, or you may have to increase the dose, etc., for the patient. But this happens when you find that either the single drug alone was not able to take care of the problem, so you keep stepping up. This very often happens happens in the treatment of hypertension, asthma, and the same is true in pregnancy. You may have to step this up as per the requirement. But many times people start with the combination therapy, saying that eventually you may need to add both the drugs, or eventually you may need to use these 3 4 5 drugs. So why not start them right in the beginning? So please, again, as far as in connection with pregnancy is concerned, better would be to go by step and try to keep the minimum drug number of drugs here. Then very important part of the standard treatment guideline is assessment of response to therapy. Very often we are quick to start with the medications, but we don't assess response to therapy, whether it is helping or not, and which one, while you step up, you may keep on adding the medicines here. But we've seen in my experience, I've seen step up is done nicely to control the patient, but unfortunately step down is not done. Once the condition is controlled, patient is better, well controlled, then you have to look for an opportunity to stop the medicine if you can, withdraw any of these medicines. So usually the formula is last in is first out. That's how you go on decreasing the number of, otherwise it will increase the pill burden on the patient, and the risk of harm to the patient, especially during pregnancy. Then of course patient education is important here. Another thing that you need to look at is whichever standard treatment guidelines you follow, these needs to be evidence based, up to date, comprehensive, provide you stepwise treatment along with the criteria for use. And a step down is equally important. For whenever you are going about pharmacological drug treatment, you need to weigh whether this drug is efficacious, safe, and what is the cost of, we are concerned about the cost of the treatment, not the cost of a unit. Some single dose therapies may be cheaper, more cost effective than other drugs which are to be given thrice a day for 7 days, but the per unit cost may be lower. And then look at the suitability, whether it is suitable for your patient or not. So all of this is going to work well if we know what is the aim of our therapy, what is it that we want to reach, what is our therapeutic goal. All these things are though may sound simpler here, but in practice there are a lot of difficulties that we face. So standard treatment guidelines help you out, come to your rescue. You can follow this, and standard treatment guidelines help you in prioritizing the treatment. For example, in this patient who presented with shock to you in the emergency department, you offer this normal saline push with 20 cc per kg, and the instruction perhaps is also correct, but what is missing here is that the oxygen is the first step that you need to do it. So standard treatment guideline will tell you that start with oxygen first, and then go on with establishing IV line, and then administer this, then take the history. First is to safeguard the patient, and similarly for the mother and child health care, we do get preterm labor. There are several reasons for preterm labor. The typical textbook recommendation would be like this in this sequence, but perhaps embryo reduction in multiple pregnancy may not be the feasible option at the secondary care. So STG will tell you these things in context of your own environment, depending on your infrastructure, the personnel available, what should be done in a stepwise manner. So similarly, there may be conditions which require a very complicated dosage schedule. You need to give a push or a bolus over 10 minutes, 5 minutes. So all these things, instructions are provided. Specifically, textbooks may not mention that these things in so much of detail. So lastly, the patient is the our the all that care that we are trying to provide is for the patient. So we need to consider their viewpoint, what is it that they are suffering. So I think we need to listen to the patient and empower them. We must use all opportunities, especially for medication use in pregnancy. We must devise methods to educate them, not to self-medicate or take medicines over the counter. So patient education remains a very important part. The advantages of following SDGs is that you don't have to look around for this information for if the patient is coming in. Those recommendations have been formulated by the experts looking at the evidence. So people it helps all levels of practitioners, especially those are few who are at the peripheral level. It helps them in educating. It helps you in deciding when to refer this patient to a higher level, depending on the availability of infrastructure and the personnel. Sometimes we just refer patients to a higher level, but you may be able to treat this patient at the your own health facility, provided you know what is to be done. Or sometimes the referral becomes futile because the referral place also does not have the necessary requisite infrastructure or personnel. So unnecessarily the patient keeps shunting between various levels. So standard treatment guidelines tell you when to refer, when not to refer, what is the criteria for refer, where to refer this. So you can then supply is improved. Also the other advantages that it utilizes only formulary medicines. And as part of the NQAS, one of the requirements in the inputs is that the facility is using standard treatment guidelines, whichever have been some. There are some which have been prescribed by the government. NHSRC developed about 12 guidelines. Snake bite was one of them. Hypertension was one of them. Trauma. So there are few which have been made by the NHSRC. Then ICMR has come up. So whichever you like, you think that ours is also there. So whatever you like, which is more suitable to your level or your practice area, you should follow this, because these SDGs, if you are not following this, there are chances that we may get entangled into violence, agitation, because these days patients, all adverse outcomes or negative outcomes, patients think that some negligence has happened. So but which may not be true. They may be, but we get involved in it, because if we haven't followed the standard treatment guideline, then we will not be able to justify why a particular treatment was given. So it is good that you follow this to safeguard against any it's better to spend some time on documentation, some time on consulting the guidelines, rather than spending hours and days and weeks and lakhs of rupees on the court cases. So these are the advantages of this. I would stop here. Next session would be on 20th May. This is again a third Saturday. I'll be talking about adverse reactions. How do you identify and manage these? And we will have an expert speaking to you about post-operative care of the cataract. I think I'll stop here. Dr. Arun Goyal is there. He's waiting. Over to you, Dr.
Thank you, ma'am. Thank you for your valuable knowledge on prescribing the safety with special to pregnancy and lactation, along with the importance of standard treatment guidelines. Our next resource person is Dr. Arun Goel. He's a consultant plastic surgeon and head of unit at Loknayak Hospital and also associated with the Maulana Azad Medical College, New Delhi. He has 37 years of experience in burns and plastic surgery and published numerous articles on burns in national and international journals and books. He was a former founder, assistant editor at Indian Journal of Burns and since 5 years, and also an editor for Principle and Practice of Burns Care. Also a MCH examiner for various universities. He was awarded with Selfless Service to Humanity, Outstanding Member by DMA, and Certificate of Excellence by Medical Director, Loknayak Hospital. I welcome you for the STG webinar, sir. I request you to take a session on burns care clinical practice guidelines. Over to you, sir.
A very good afternoon to everybody, especially Dr. Shrivastava, Dr. Sangeeta Sharma, and all others present here, and all my friends and colleagues, who are listening to us, sitting here and in the webinar. Now, my topic is on burns. What are the standard or the clinical practice guidelines? Now, burns is the oldest, worst, and unique form of all the tragedies which can affect the mankind. The patient initially struggles for survival and later struggles for returning to society because of scars and deformities. When these patients come to us with extensive burns, the relatives, they want me to keep them surviving and make them healed. But later on, once they heal, after my months of efforts to save them, they come to me, what is this patient? This is only scars and deformities. So they are not happy again. So this is the reason why they cannot return back to society. And as you can see in these pictures, although this patient on the upper right side and lower right side, they are normal, they are normal in the sense they are surviving. But do you think that these patients can ever go back into society? They can only sit at home covering their faces. Now, coming to the burns proper history, prehistoric man must have suffered from burns due to lightning, forest, hot springs, forest fires, and hot spring and other natural things. As you will be surprised to know that as far back as 2600 years from today, Sushruta, who was a practicing surgeon in Banaras in India, he described clinical symptoms very accurately. And since then, or even before that time, everything under the sun has been applied on the burn wound. And like you know, that Chinese and Japanese, they were experts in making tea. So they used tea leaves extract to cover the burn wound. And then many people who were on the beaches, they used animal oils and animal fat. And then honey was also used. And even today, we see patients who are coming to us and they have applied fountain penning or toothpaste. Another thing which we find now in our cities is that every patient who comes to us, he has already applied silver sulfur diazine. I think silver sulfur diazine has been only misused by the public, and I will tell you what is the reason later on when we come to this drug. Now, we know Joseph Lister discovered microbes in and for this silver nitrate was used And after that, we developed techniques of skin grafting, fluid therapy in last 100 years, and then detailed body surface area charts were made to estimate the area. Specialized burn centers were developed, and skin cultures were being developed to replace the burnt skin. Now, I always say that the burns is not a medical problem in India. It may be a medical problem in USA or UK, but ours is a medical social problem. Number one, the exact data for burns is not available, but we know that several millions must be burned every year. Poverty, illiteracy, large family size, small living space, congested areas, they are the reasons why this is a problem in India. Then there are poor standards of safety at home, at workplace and industry. You must have seen that many reports come in the newspapers that in many factories they were on fire because of the poor standard of safety. Unfortunately, carelessness seems to be ingrained in our blood. We tend to be careless. So this is one of the biggest reasons in our country. Then there are poor number of dedicated burn centers and burn surgeons. The place of accident can be at home or workplace, moving vehicle, pandals made of inflammable material, forest fires, etc. And during Diwali and other festivals, when we play with firecrackers or fireworks, again we get a number of burn patients. And then in our country, there are poor quality electrical fittings and appliances. And we also find that there are very low lying high tension wires on houses. And these high tension wires sometimes fall on buses and cars or in the fields. And one thing which people have not realized that in our country, now almost all the trains are electrified. So they still believe that the old practice of sitting on the rooftop of trains when there is a lot of rush, they sit on the rooftop and they don't realize that there are heavy tension 44,000 volt wires going on that, which can suck them and they can get electrocuted and fall on the ground. Now, the burns can be accidental, suicide or homicide. In most of the advanced countries, they are accidental, but it is special that in our country, suicides and homicides are also there. Fire in our life, it is used for cooking food and ovens and other things, but it is mostly misused for committing suicide and homicide, as well as for destruction of evidence of crime. Accidents can occur anywhere in the area. Now, what are the modes of injury? We all know that the burns can be due to heat, which can be dry heat or flame. It can be wet heat or scalds. That is because of the hot liquids in the kitchen. And then it can be electrical burns, chemical burns, which are commonly acid burns, and then radiation burns and friction burns. Radiation burns, now I am seeing much less because most of the advances in the technology of delivering the radiation to our cancer patients has improved so much that the skin is always spared. Now, Jackson gave a burn wound model. What this model is, it is very simple to understand. The area where the fire started, or the area where the liquid fell down, or the area where the current actually touched the body first of all, naturally that is dead. So that is known as zone of necrosis. That is the central part. Then there is a zone surrounding it is a zone of stasis. That is, this area is dying. This is still live, but correct resuscitation, early resuscitation, proper resuscitation can positively influence on this area. And then surrounding or the outermost area is zone of hyperemia. That means it is live, but it may become involved if not treated properly. So if you find in these diagrams, the uppermost diagram shows the central black area as the dead area, the outermost red area is the living area, and the intermediate area, which is orange in color or yellow in color, that shows that it is the dying area. So if the patient reaches to a right person and the right treatment is given, whether with first aid or proper treatment, this dying area can become living. So the area of dead area will become much less. On the other hand, if proper treatment is not given timely, proper first aid is not given, this area will also become dead and the total burn amount will increase. Now, so first of all, we will go into the how to assess and record the burn injury. And why I am telling all this is that because many people believe that burn means a small area on the body over which some sort of ointment or some cream or something has to be applied. But it is not so. A burn is a very big thing. It not only involves the skin, it involves all the body systems, especially the major burns. So you have to do accurate assessment of the burn, and the treatment is not so simple that it is application of silver sulfadiazine. As a prognostic indicator, once the patient comes to me, naturally the relatives want to know what is the prognosis, especially in a major burn, whether there are chances of survival, whether there will be need of surgical interventions, how much time the patient will take to recover, what will be the amount of money involved, and how much will be the scarring. And to know the progress of the patient over a period of time, naturally we want to have an accurate record what was the patient's condition at the time of admission and what is the position after 7 days, 15 days, 20 days. And then you must be knowing that most of the cases of burns in our country, as they are socio-medical problems, they are medical legal cases. So in the court of law tomorrow, when I am called for the giving evidence, I should have the records which are maintained properly. And you should also know that many patients come to us afterwards to settle insurance claims or workers' compensation. Or sometimes in the case of disasters, the government gives some compensation based on the extent of injury. There, a burn surgeon or the doctor is required to justify and tell the government that this was the extent of burn, so this patient should be given this much amount, and this is the patient who was having more burn and he should be given that much amount. And then for research purposes also and medical audit, we should have an accurate assessment of the burn as well as recording. Now, this assessment is crucial also for calculating the fluid requirements, which we will discuss later in the part of our journey to the management of the burns. So the history is taken, general physical examination, systemic examination is done for everybody, other patients also. Now, coming to the burn wound itself, the burn wound itself is assessed with respect to two things. Extent, what is the percentage of the burn, and depth, what is the depth of burn. So first of all, we should see what is the age of the patient, because extremes of age, pediatric age group and geriatric age group, they are highly susceptible to burn, and the mortality and morbidity is more. Date and time of burn, it is to be mentioned on the records, because this is very important. Because when I start the treatment of the patient, I start the treatment not according to when he came to me. I start the treatment according to the time of burn. At what time the patient was burned, whether 10 hours back or whether 20 hours back or whether 1 hour back. So my treatment timing will be according to that. So that is very important. Plus this time of burn, actual time of burn and delay which occurs, in the court of law, I will be safeguarded by saying that the patient came to me 24 hours late. So I was giving proper treatment. Still the patients come to injuries because he came to me late. Otherwise, people may say, no, why should he die? So that is the reason. Then naturally, whenever there is an injury, we should see what are the other additional injuries. And also we should see whether there is any associated illnesses like diabetes, cardiac diseases and others, and whether he has received the first aid or not. Plus one thing more which you have to know is where the patient was burned. Most of the burn patients in India which come to us, they were at places where it was not a closed space, or patient was sitting in home or workplace was such that it was open air. But now for last few years, we are finding that because of tall buildings are there which are fully air conditioned and closed, the environment is such that these patients may get inhalation injury also. You must have heard during the corona times in the last 2-3 years, we saw that a number of hospitals, ICUs, they got burns, and due to the closed windows and everything, because it was an AC area. So these patients or the workers there or the doctors and nurses, they were not actually burnt. They died due to inhalation injury. But most of the patients who come to us, they are not in the closed space because AC is not so commonly available in our country. Now, first of all, when we write the details, we should write history given by the patient. Most of the patients, 98-99% patients who come to us, they are conscious. So because it is a medical legal, we should take the history directly from the patient. And when we start writing, because most of the patients, they may not be telling you the right history. There may be something fussy. or fishy in that history. So we should start writing the history as alleged history of getting burnt by so and so, because I have seen a large number of patients of major burns, they tend to change their history after some time when they are told by the relatives and other people who are vested interest to change the history. So if the history is not given by the patient, then I should write why it was not given by the patient, whether he was unconscious, he was uncooperative, or confused. But most of the times, if the history is given by the patient, and in case history is taken from some other close relative, then I should also mention his name and write his name and relation in the record. Plus, I will also explain the prognosis also to this person. Now, this is common to all trauma patients, but most of the patients, as I have told you, these things are not important, because the patients come to us, they tell that the patient was working in the kitchen and she caught fire, or the child was playing in with a bathroom tub and he suddenly got burns due to hot water. So, but still, this is the standard practice. And in general physical examination, systemic examination, when a patient comes to me and tells that he fell down from the rooftop of the train, moving train, naturally you expect that there can be fractures, head injury, etc. And you should also know that most of the times you must have heard in newspapers and media, TV, etc., that many female patients were found who were burnt and found in a village or farmhouse or something, and there in the patient there is a risk or there is a suspicion that the patient was initially raped and then she was burnt and thrown into the outside fields. And so we should be suspicious of that also. And in all these patients, the weight of the patient is taken, because this will come handy in later calculations. Now, coming to the assessment of the burn wound itself with respect to extent and depth. Now, the extent of the burn is taken as the percentage of total body surface area burned. This we call as TBSA. It has to be estimated to know whether the patient has a very high area, so this patient will need transmission or referral to a higher center, or whether the patient needs intravenous fluids and what will be their amount, and then whether the patient will survive with this extensive burns or not. For assessment, the burn victim is classified into minor, moderate, or critical burn patient. And if the patient is critical and sometimes moderate also, the patient is referred to appropriate higher burn center if required. Now, there are various techniques of how, or formally, how to measure the extent of the burn. Now, this is a Lund and Broder chart, which is a very detailed chart based on age as well as the area of the body. This chart is actually required because you know the head size of the child, newborn infant, is almost 20-21%, whereas in the adult it is only 9%. And on the other hand, the lower limbs, lower extremities of the newborn are almost equal to the upper extremity, whereas they are double in adults. So this detailed chart is required to measure the area of the burn which is involving the patient. But most of the time, because if the patient, the area is not a burn center, these charts are not available. So we have to have some simpler mechanism of estimating the burnt area. What are those? So most commonly we use Wallace rule of 9. You must be knowing that there is a Wallace rule of 9 which says it is easier to remember, quicker to use, and does not require any chart. And this divides the whole body areas into 11 areas of 9% each. Head and neck is 9%, front and back of chest are 9% each, front and back of abdomen are 9% each. Each upper extremity is 9%, and each lower extremity is 9 into 2%, that is 18%, and 1% we keep for the external genitalia. Now in children, because the head size is bigger, we use rule of 5. This rule says, it is also very easy to remember. It is head and neck is 20%, front of trunk 20%, back of trunk 20%, and each limb comes to 10%. So this comes to 100%. But this is true only for the neonate 1 year, 2 year child. So as the child becomes bigger and bigger, you have to use some modifications. When the head size becomes 15%, each lower extremity becomes 15%, the upper extremity remains 10%, the front of the trunk is 20%, and the back of the trunk is 15%. So these modifications are done in the rule of 9 if the patient is slightly smaller, not adult or less than 12 years. Now, rule of palm or hand. We should remember what is rule of hand. Actually, it is not rule of palm, although it is a misnomer, because anatomically palm is a different definition and hand is different. In this rule, it is really hand. That means whole of the palm as well as fingers and the palmar surface of the thumb also taken together becomes 1%. And this 1% is for me. My hand is 1% for me, your hand is 1% for you. So you cannot measure the patient's body surface area by keeping your own hand. Rather, you have to keep his own hand. But in general, practically what we do is that we see what is the age of the patient and the size of his hand. Like if the patient is a smaller kid, and I know my one hand is equal to his 5 hands. So once I keep one hand of mine on his burnt area, I say it is 5%. So this is used basically for scattered burns or small areas. Now coming to depth of burn. Now earlier there were various classifications where the depth of burn was classified up to 6 degrees. But that they were not useful because it is not possible to classify depth of burn into 6 degrees because we are not doing biopsy of the patient. We have to see what is the clinical finding. On that basis, we have to decide. So the most important thing which we have to know is whether this burn is partial thickness or full thickness. That means whether partial thickness of the skin is burned, full thickness of the skin is burned. If it is partial thickness of the burn, I am sure that this wound will heal of itself by remnants of the skin. But if it is full thickness of skin which is burned, naturally I know this wound will never heal, and this will require surgical intervention in the form of skin grafting. But this is a very simpler classification, so we have got a slightly more useful classification in the form of degrees. The first degree is epidermal burn. The second degree is further classified into superficial dermal and deep dermal. Superficial dermal is epidermis plus a papillary layer of the dermis. Deep dermal is epidermis plus papillary dermis plus reticular layer of the dermis. Third degree is equal to the full thickness burn, which I have told above, and even deeper structures. But sometimes people don't take this deeper structures into third degree and they call it as fourth degree. Now, how to estimate the depth of burns? Naturally, we are treating patients, and so we have to take the history. What was the temperature of the hot water or tea? What was the fire? How much time was taken to extinguish fire? What is the appearance of the burn wound, whether it is pink or white or whatever? Whether it blenches to pressure, what is the sensation? Naturally, a sensed wound will not be dead completely. If you can pull the hair without causing pain to the patient, naturally it is not dead completely. And then from retrospective angle also. When the patient comes to me after 6 months, I ask him in how many days you healed. He tells me I healed in 30 days. I can tell what was the thickness of the burn. If he tells I healed in 10 days, I can tell what was the thickness of the burn. So from retrospective also, we can also base. So the first degree, it involves epidermis. It is erythema, mild pain, swelling, no blister formation. And this is only sunburn. So I never treat this burn. Nobody comes to me for sunburn because the patient knows that he visited the hill station and there he got sunburn, and it will take 3 to 5 days to settle down. And we do not classify it in our patients when we calculate the area of burn. Now, second degree superficial dermal burn, it involves, as I have told you, epidermis and papillary dermis. There is severe pain because of exposure of the nerve endings, which cause pain when the air blast passes over it. And they are pink and moist in appearance. There is blister formation. After the blister is de-roofed, the undersurface is pink, moist, and weeping, as you can see in these pictures. And they heal in 10 to 20 days from the remaining skin appendages, which are sweat glands, sebaceous glands, and the hair follicles. Second degree deep dermal burns, they are waxy white in color. They are soft and elastic. They take more time, 3 to 4 weeks, and sometimes even up to 6 weeks. And they heal by hypertrophic scarring, especially if they take more than 4 weeks. And in the lower part of the back, you can see there is a waxy white area in the center over the spine. Third degree burns, they are full thickness. And in this, there is a tough, dry, inelastic, translucent, parchment-like appearance. This skin is known as, dead skin is known as eschar. It is painless, obviously, because there is no skin left. And there are visible thrombosed veins underneath, and this separates out gradually in 3 to 4 weeks of time, and it reveals granulation tissue which cannot heal of its own, and it requires skin grafting. 4th degree burns, you can see even the muscles and bones are involved. Now, first aid for burns, they start from the time of burn where the patient got, and somebody has to treat. And for the first aid, you have to give ask the patient to stop, drop, and roll. Do not run, because once the patient is running in a standing position, definitely whole of his body is causing his burning in the feet. Now even a head will also get involved. So he should roll, drop, and roll. And then you should take the patient away from the closed space if it is unventilated to open space to avoid inhalation injury. And you have to try to extinguish the fire by putting some jacket or thick cloth over the flames to cut off the oxygen supply. You should not try to beat the flame in an effort to extinguish, because it gives more air to the flame. Now, our principle is that pour water on burns. Now, question arises, what temperature of water? I always say water which is available. If I say that water should be at 20 degrees centigrade, the public has no way of getting that 20 degrees centigrade. If I say 10 degrees centigrade, public has no way of getting that 10 degrees centigrade. So the temperature, and our aim is to bring down the temperature of the skin to normal 37 degrees centigrade, and not to bring it to 10 degree or 5 degree or 15, 20 degree. Never put ice on the burn, because vasoconstriction reduces blood supply and it increases the depth of burn. And if you immerse a patient victim with large burns into cold water, this may lead to hypothermia and shock, especially in small kids. Sometimes the patients put the child into cold water. So this should not be done, and just try to bring the temperature down to 37 by pouring water which is available nearby, and it is at room temperature. By cooling the area, you are reducing the extent and depth of burn, you are lessening the swelling, it relieves the pain, and also naturally the prognosis of the patient will be better. Now, this area is covered with a clean sheet, not with a sterile sheet, because sterile sheet is not available anywhere other than the hospital. Do not apply any ointment, cream, or any medicine like Ratan Jod, toothpaste, ink, etc., because once the patient reaches the doctor, it will not be possible for him to judge the extent of burn, and then immediately shift the patient to nearest medical facility. Now, coming to the treatment proper, I will say that the treatment of the burn patient is most methodical and standard, and it is based on scientific guidelines, which you will know that it is not just application of silver sulfadizine or one tube or one ointment or one cream. So I always say that I do not know which is the best drug for treatment of burn patients. All my patients know that silver sulfadizine is the best drug for the treatment of burn patient. It is only I who do not know which is the best drug. And you will also at the end of this talk know that there is nothing like best drug. So although I will discuss the treatment under various headings, but all these things, including the diagnosis, including the measuring the extent, they were not going alone, one after the other. When I was measuring the extent of burn, my sister has already given a tetanus toxoid to the patient. And as all wound patients receive half ml intramuscular dose of tetanus toxoid, these patients also are given. And those patients of mine who are minor burn patients and who are ultimately treated on OPD patients, at the end of my treatment on that first day, I also asked them what was their immunization status with regard to tetanus. And if they know about it, it is good, and then I advise accordingly. Otherwise, if they don't know, and then I tell them, okay, come after 6 weeks and 6 months to get the second and third dose, so that this tetanus immunization is complete. I also tell them that this first dose which I have given to them, it is useless unless all the 3 doses are given. So in this way, I make them a little scared that this tetanus treatment will be complete only after they get the 3 doses. So they come back to me after 6 weeks and 6 months also. Now, the second thing which is going on with simultaneously with the measuring the extent of burn is that the patient is asked nil orally, or very rarely I also put rice tube. Now, why this nil orally? Because you have to know what is the gastrointestinal response to a burn injury. There is a gastroduodenal paralytic ileus. There is decreased gastric mucosal blood flow. The small bowel mucosa may atrophy. So these things, this ileus says that you should not give the patient anything orally because it will lead to distension of the stomach and vomiting. And this patient, if he is semi-conscious, he may aspirate the thing. So these patients, but you should also remember that this gastrointestinal response increases as the percentage of the burn increases. In burns which are less than 15%, this gastrointestinal response of paralytic ileus is practically nil. So rather in these patients, I advise them to take more of fluids rather than advising them not to take anything orally. It is only those patients where almost more than 25-30% burns that the risk of paralytic ileus is great, that I watch for some time. And if it is more than that, I do not even watch. I have to put them on nil orally till I judge that yes, they can be given orally. So this response, this thing of nil orally is not valid for everybody, but I see if the patient is more than 40%, he will remain nil orally. Now, these patients, why the burn patients need fluids and what should be their composition? Whether they can be given oral fluids or they need intravenous fluids. Now, following a burn injury, there is an increased capillary permeability which leads to leakage of protein-rich plasma-like fluid into the extracellular space. In extensive burns, more than 30% total body surface area, this phenomenon is not limited to the burnt area, but occurs throughout the body. And several vasoactive mediators like histamine, serotonin, kinin, etc., they are the cause of this response. And this capillary integrity gets restored within 18 to 24 hours after injury. So there is a leakage of proteins, and this protein-rich fluid which gets into the extracellular space, this causes shock. And naturally, because this response is not there in patients who are less than 15%, they do not require fluids and they do not require nil orally, and they can be sent home. So what is the best treatment? Our principle in plastic surgery is replace like with like. So the best fluid which should be given is plasma. When the plasma is being lost, the plasma is to be given. But the problem is there is no availability of plasma, and then there is risk of this disease transmission. So the next best thing is plasma substitutes in the form of colloids like albumin, dextran. Yes, they may be available easily in a big city like the metropolitan cities or the capital of the country, but they are costly. But what is the scientific reason why don't we like them also? Because the problem with plasma and colloids is that they cannot come back into the circulation after 24 hours, after the capillary permeability is restored. And this leads to edema formation. So what is the answer? Crystalloids. They serve the purpose well. They are very cheap. They are easily available in even the remote place in the country. And the biggest thing is that they can return back into circulation after capillary permeability is restored after 18 to 24 hours. So although it is the plasma which is leaked, a ringer lactate or a normal saline bottle can serve the purpose. So this plasma leads to loss, as I have told you, leads to shock. Less than 15%, the shock is nil practically. So I advise them that they take plenty of liquids, but whether they take milk or coffee or whatever, I do not mind. But sometimes if it is really around 15%, then I advise them to take a few sachets of ORS on the day one. Then if it is a burn which is 15 to 40%, in most of these patients, they are given IV fluids. But in burns which are towards 15%, some amount of fluid can be given as ORS. And if it is a burn which is more than 40%, I give only IV fluids. So if there is no alienation injury and the burns does not induce or initiate systemic inflammatory response because it is less than 15%, these patients can be rehydrated successfully orally only. Now, what is the consideration in fluid requirement? During first 24 hours post-burn, my aim is to restore the patient's blood volume and electrolyte homeostasis. Minimal amounts of fluid which are required to restore cell function should be given, and electrolyte deficits are corrected promptly. Now, this also restores and maintains perfusion pressure, leading to maximal oxygenation of the tissues. And for this, various formulae have been devised, but the basic principle is sodium ion, which is the most important component, and this was recognized in 1923, that is exactly 100 years from today. All formulae, however, they end up by saying that they are guidelines only or starting points only, and careful clinical and biochemical monitoring is essential to make appropriate modifications and optimal result in an individual case. So in olden times, when the trains were always late, people used to say, why there are timetables if the train has to be late? I always used to tell them the timetable is there so that you can know that the train is late or not in late. So when the patient comes to me, I can tell my sister, my residents, that start with this much amount of fluid, and then I will watch the patient and make modifications. But if I do not know the formula or the guideline, how to start the fluid, nobody can start the fluid at all. Now the formulae, like I have told you that the plasma is to be replaced. So I have given three formulae here, Evans formula, Brook formula, and Parkland formula. The two are to be only known because of historical importance. The third is to be remembered, and the patient is to be treated by that formula. Why I have given the first two formula? Because in Evans formula, he believed that I should give at least 50% saline and 50% colloid. But Brook found that even 75% ringer lactate will work with 25% colloid. Then Parkland formula was believed that no, 100% ringer lactate can be given without given even an ml of colloid. So this is the formula which is being used the world over commonly, and the other two formulae have been rejected because of the colloid problem, which I have told you earlier. So what is this Parkland formula? One thing which you have to know about the Parkland formula is, while the Evans and Brook formula were devised by Evans and Brook, the name of the people, but the Parkland formula was devised by Baxter. He worked in Parkland Hospital. So he credited this formula to the name of his hospital. So you should not call this Parkland formula as the name of the person. So what is this formula? It says that the patient is given 4 ml of fluid multiplied by weight in kilogram and multiplied by total body surface area burnt, which we have already calculated. Now, half of this volume which we have calculated of ringer lactate is given in the first 8 hours post-burn. And this post-burn is decided, again, I am repeating, from the time of burn, not when the patient comes to me, maybe he's 8 hours late or 2 hours late. And with the remaining volume given over, infused over next 16 hours. In the second 24 hours, the fluid requirement is usually around half of the first day requirement, and colloids may be added at this stage because the problem of edema and the problem of return back into the circulation is not there now. Now, depending upon the bowel activity, whether there is abdominal distension, vomiting, ileus, passage of flatus, etc., which I examine the patient on daily basis multiple times in the ICU, especially in the extensive burn, the patient is gradually started on clear liquids, then semi-solids, then full diet, and then high protein diet, and then high calorie diet over a period of 5 to 7 days. And naturally, over this period, the IV fluids are correspondingly decreased. But one should know that patients with inhalation injuries, associated fractures, and electrical burns, they do require larger amounts of fluid. When a burn patient is transferred to me in a burn center, specialized burn center from an outside hospital, several hours after the burn, and in that case also we should see how much fluid he had received, whether he was under resuscitated, over resuscitated, and I should reflect this into my calculations and not just go on by my calculations only. Now, what is the systemic response of thermal injury to the kidney? This I have told you earlier that burns is not a skin disease, it is a whole body disease. So when the burn is there, extensive burn is there, now more than 25-30%, there is decreased renal response. So decreased renal blood flow, which leads to shock. There may be renal tubular damage if it is prolonged, and there may be oliguria, and ultimately acute renal shutdown may occur. So for this, giving IV fluids and preventing renal shutdown, we have to establish wide bore IV lines, and sometimes in larger burns, critical burns, we have to use 2 lines together, and a cut down may also be required. A weight measurement, I have already told you these formula require. So we have to take the weight of the patient, and because we have to measure the urine so that I can see whether the kidney is functioning or not, I have to put a catheter also. Now, what is the treatment? Now, naturally, patients who come to us, they complain of pain. And let me tell you, the more the pain, lesser the burn. It is reverse. Most of the people think that if the patient is crying more, it means he has more injury. No, it is if the superficial burn, especially the superficial dermal burn, which I have told you has exposed nerve endings, he will be crying, and it is say 5%, 10% burn, he will be howling at the top of his voice. In 100% burn, 80% burn, especially full thickness burns, his all skin is dead, there is no nerve ending, he will be lying calm, because there is no pain, there is no skin, there is no nerve ending, they all are dead. So, but if the patient is going to be treated on OPD OPD basis, these patients I prescribe paracetamol, maybe syrup or tablet depending on the age of the patient, dose according to the age of the patient. Sometimes the patient is still not satisfied, I may give an injection of diclofenac sodium single dose at the time of his first presentation, but later on, the biggest way of treating the pain in a burn patient is doing an excellent dressing, because that will cover the nerve endings and the pain will be relieved. However, for patients who are admitted, they do need analgesia and sedation, because they have got not one type of burn. The extensive burn may be some areas may be superficial dermal, some may be deep dermal, and some may be full thickness also. So these patients are generally given narcotic analgesics in the form of pentazocine, morphine, and pethidine. But nowadays, even paracetamol is also being tried intravenously. But these patients are to be given these narcotic analgesics. But it must be noted that the cause of jumping of the patient in the ward, howling, is not pain, it is hypoxia and hypovolemia. So they must be treated by giving IV fluids. And it is not that one surgeon comes or the one doctor comes, he gives the injection pentazocine, and then after 5 minutes the patient is still howling, and another person comes, he gives another dose, and another third person comes after 10 minutes, he gives another dose. Because as soon as his hypoxia and hypovolemia will be corrected, he will have received 3 times the dose he should have been given, and leading to respiratory depression. So these patients, IV fluids are a must to be given before these patients are given all these narcotic analgesics. Intramuscular or subcutaneous route should never be used in these patients, because fluid resuscitation can result in unpredictable patterns of uptake. Till the patient is resuscitated well, his perfusion blood pressure is normal, these routes will not lead to absorption of the drug, and suddenly once this restoration is done of the status of shock, the patient will get these drugs absorbed into his circulation. So this is the way how we treat the burn. And narcotic analgesics cannot be given on the OPD basis, because in that case, the patient has to be kept at least for 4 to 6 hours in my OPD area, because a narcotic cannot be given on a home basis. Now, we also give them H2 receptor blockers. Why do we give them? Again, fundamentals have to be learned. The patient, all these burn patients, they get stress ulcers, which are known as curling ulcers. They are gastroduodenal ulcerations, and which may be so severe in cases of extensive burns, 80% burn, 70%, 90% burn, that they may even lead to hematemesis, bleeding. So these patients are to be given. But if the patient is say 5%, 10% burn, this stress is so minimal that you don't have to give anything like this drug. So when the patient is admitted, initially he is given injection of ranitidine or pantoprazole along with antacids. But once the patient is on oral, he can be switched on to oral doses of ranitidine or pantoprazole, and antacids may also be given initially, and this stress may be taken care of. And naturally, people will ask how long this is to be given. The answer is very simple: till the stress is there. So once you find that the patient is recovering well and the stress has decreased, you may stop these. Now, once we are doing all these things, I have told you earlier that they are not one after the other. All these things are being done again. So remember, we are also taking the pulse of the patient, temperature of the patient, respiratory rate, and signs and symptoms of dehydration, how they are improving, how the restlessness is improving. And then we have taken the weight of the patient to calculate the various fluid formulae. So these things are very important. At the same time, we have taken the blood samples when we started the drip to take hemogram sample for hematocrit and biochemical investigations like kidney function test, liver function test, and the plasma protein levels. So these things are done. But and one of the most important thing of monitoring is that all these things of pulse, temperature, respiratory rate, they may not be the true reflections in the initial period. So the best thing is 1 hourly urine output. This is the considered as the best clinical indicator. If the patient is to be managed, if the patient is passing normal amounts of urine, normal means desired, which I will tell you later how much is desired. If the patient is passing desired amount of urine on an hourly basis, that means his perfusion of the kidney is normal, and that means that his perfusion of the brain is normal. So that also means that my fluid is also normal. If he is passing less urine, then I have to give faster rate of fluid. If he is passing more of urine, then probably I have miscalculated somewhere and I have to decrease the rate of infusion. So this monitoring by hourly urine output is very important. On second day onwards, I also send blood wound swab cultures, and then every 3 days, because we have to monitor the wound status also with respect to the various pathogens. And in case after several days, the patient may, if the patient is of extensive burns, show signs and symptoms of septicemia, blood cultures may also have to be done. And sometimes after 2, 3 weeks, 3 weeks, 4 weeks, we find that the wound cultures show no bacteria, but they are actually replaced by the fungi. So in that time, sometimes fungal cultures are also sent. So in addition to this monitoring, I also draw a diagram in the records so that I can show what is the wound healing status, and after 1 week, after 2 weeks. And at the first diagram, when we make the patient's diagram on the first day at the time of first presentation, we also label which areas are partial thickness, which are full thickness, which are superficial dermal, which are deep dermal. So all this monitoring is also done along with what we are discussing of the patient. Now, once we have got these things done, naturally, if the electrolyte report comes imbalance, shows imbalance, we have to correct that. Packed cell volume has to be kept not more than 32%, because this will lead to hemoconcentration and poor flow in the capillary. So poor flow in the capillary of the burnt area, which will mean that the poor circulation of the burnt area, that means this area which is already poorly vascularized, this will go towards death. So we have to keep the blood a little more fluid as compared to a 45%, which is there for the normal person. So, hemoglobin, many people ask whether we should give blood to the patient or not. When should we give blood? Again, scientific principles dictate then on the first day, if we are not giving plasma, we are not giving blood also, because both are colloids, and which we have seen why we are not giving. But in patients who are having, say, fractured femur also, and his hemoglobin is, say, 5 gram, naturally, we are not fools. We have to give treatment for that 5 gram hemoglobin. So except in those cases where we have to give blood, say on the first day, we do not give blood. And after second day, third day, fourth day, we are watching the hemoglobin status and we are giving blood according to the blood hemoglobin reports. Try to maintain it above 10 grams so that the healing is normal. So now coming to what should be the urine output. Urine output is desirable. Urine output is different for different status of the age and type of burn. It should be half to 1 ml per kilogram body weight per hour in small children. It should be 1 ml per kilogram body weight per hour in adults. And it should be 2 ml per kilogram body weight per hour in electrical burns. Why it should be more in electrical burns? Because in electrical burns, there is damage to the muscles also. So there are myoglobins and hemoglobinuria also. And to flush that pigments, we want to give more of fluid. And sometimes in these patients of electrical burns, if these pigments are more, we may have to flush the urine by giving mannitol. So this is additional item which we give to these electrical burn patients if they are not showing the clearing up of the urine. Now, based on all this, what we have seen, we have to decide what is the critical burn. A partial thickness burn of more than 5% total body surface in infants, more than 15% in children, and more than 25% in adults is a critical burn. Full thickness burn, more than 15%, 10% in adults, and more than 3% in children is a critical burn. Naturally, hands, face, and perineum, they are special sites. And then there may be associated fractures, head injury, etc. They are also critical. Inhalation injury is always critical. Electrical burns is always critical. Chemical burns which involve the eyes, we consider them as critical. So these patients always need critical admission, and especially in a burn center. Then the other burns are moderate burns. These burns can be treated by even non-specialized burn centers, and they are partial thickness burns from 10 to 15% in children and 15 to 25% in adults, or full thickness 1 to 3% in children and more than 3% to 10% in adults. These patients can be treated in less than specialized burn centers. The minor burn center patients, which I am telling that those are those which are treated, they are not admitted anywhere, and most of the times they are sent home by giving them treatment of pain, giving them dressing, giving them other drugs, and then they are called on every alternate or third day or whatever you see in the wound. Now burns, I have already told you that when I am discussing all this, I am not alone. A major burn cannot be treated by one person. I am the leader of the team as a burn person. So the burn surgeon is the leader. He has to be accompanied by nurses, dietitian, physiotherapist, anesthetist, occupational therapist, respiratory physician, therapist, social worker in the last stages, physician, pediatrician if the patient is a child, and then microbiologist and other people. So these people are also part of my time when I am treating. They are not present on the day one, but they go on adding up as the patient's treatment advances in a specialized burn center. Now, while we were giving them the resuscitation part in a major burn, the wound also is being looked after. It is not that we have just started the drip and we are now sitting idle. Someone is also taking care of the wound. Now, how we treat the wound? We first of all, we do gentle cleansing of the wound with a soap solution like Savlon, and then wash it with saline, and then we dab it dry. So, and then this is applied, wound is covered with a topical antimicrobial agent. Over this antimicrobial agent, a non-stick gauze in the form of paraffin gauze or Vaseline gauze is applied. This non-stick gauze is very essential because tomorrow when you are going to remove this dressing, it is going to stick to the oozing of the plasma which is occurring in the burn wound, and it will stick to the wound, and two things will happen. Number one, the burn wound, when you remove the dressing, it will cause pain and it will cause damage to the skin wound which is there, and causing it increase in the depth of the burn wound. And this pain, sudden pain in the wound may also move the patient's limb, and he may strike you. So for at least for your own safety, you should apply paraffin gauze, if not for the patient. But I always apply non-stick paraffin gauze to the wound. Over that, I have told you that multiple layers of absorbent gauze are required because it is an oozing wound. And over that, we put multiple layers of cotton pads. These cotton pads, we call them as Gamgee pads after the name of the person who devised them. They are simply cotton sandwiched between two layers of gauze. Because if we do not put these two layers of gauze, tomorrow when I am going to remove the dressing, the cotton will come piecemeal into my hand. And it will be very difficult to remove the cotton from the wound. So I have to put the cotton into two layers of gauze, and over this finally I tie a bandage. This is the wound management. Now coming to topical therapy. Why do we require topical therapy? Why don't we give systemic antibiotics or whatever? So why they are required? Because they are required because of the poor vascularity of burn wound due to their hypovolemia, hemoconcentration, and then thrombosis of the vessels. If I give an antibiotic systemically, it will never reach the burn wound itself. So topical therapy is also required. Now topical therapy, I will start with the number 2, framycin, or what is known as commonly soframycin cream, betadine, or which is actually povidone iodine cream, nitrofurazin cream, which is available by the name of furazin cream, then triple antibiotic ointment in the form of neosporin, which contains neomycin, bacitracin, and polymyxin B. These are the drugs which are commonly used. But unfortunately, silver sulfadiazine is more commonly used on burn wounds. I will tell you why it should not be used commonly by the patients. It is used commonly by the patient because it is available in the form of 10-gram tube, 15-gram tube, 20-gram tube. If it is available only in the form of 250-gram, 500-gram jar, it will not be misused. This silver sulfadiazine was developed in 1966 by Fox to treat patients who were at the risk of developing septicemia and death. That means more than 35 to 40% burn patients, total body surface area. So most of the patients who are coming to us in our OPDs, in our emergencies, or seen by the GPs, general practitioners, or in the dispensaries, wellness centers, they are not to be treated by silver sulfadiazine. That is why I always say that while the patients know which is the best treatment, they know it is silver sulfadiazine. I know it is not the best treatment. It is the treatment to be done used for by only a specialized burn surgeon, and that too for treating patients who are more than 35% burn. Silver sulfadiazine is a very good antibiotic, antimicrobial agent. It has to be preserved for only those patients of septicemia. It is not to be misused for every 1%, 2% burn. That is the reason I say why it is being misused. So government should do something by stopping the manufacture and availability of these small tubes. Now, another drug which is available is known by the name of mefenide, sulfamylon. It is 11% available, but this has problems, so it is not commonly used. Now, silver sulfadiazine cream was used alone, then people started adding something to it to make it more effective. Like they added chlorhexidine. They added something known as epidermal growth factor so that the wounds are healing faster. But these are not really very useful as compared to silver sulfadiazine alone. Now we know that silver has been used since thousands of years as an antimicrobial. People used to drink water kept in utensils which were made of silver. You might have visited Jaipur, where big utensils of silver are available, which were used by the kings to take water to other countries when they used to visit them. I do not know whether they knew whether the silver was an antimicrobial, but today we know silver is an excellent antimicrobial agent, and that is why we can combine it with the sulfadiazine moiety to create silver sulfadiazine. Now, various nanocrystalline forms of silver are also available, which are available as a topical treatment. Now, these dressings are done till the wounds heal in partial thickness burns, or else in full thickness burns, a granulation tissue forms. And in these patients, after the wound bed preparation, culture sensitivity report, the thin to intermediate thickness skin autographs are applied by the burn surgeon. Now, while all this thing is being done, the importance of nutrition cannot be underestimated, because the burns is a severely hypercatabolic state. Major burns, they are a hypercatabolic state, and the patient loses weight very rapidly. And this nutritional requirement does not include one thing or the other. It includes carbohydrate, it includes fat, protein, vitamins, minerals, and trace elements. And this caloric requirement is estimated based on the wound size and patient weight. But for all burn patients who are admitted with me, I tell them a general principle that whatever you are eating, that you will eat even today because you are there. But in additionally, you need for the burns. And for that, whatever you are eating, double that amount you try to eat today. So you have to take 3 times. This is the general thing which I tell the patients. Although there are various formulae which estimate the weight of patient and the percentage of burn, depth of burn, and from there they calculate how much protein is required, how much nitrogen is required, how much fats are required, how much calories are required. But all these things can be done only in a specialized burn center. But these patients, if they are not being treated by the specialist burn center, they should be encouraged to take double or triple amount of nutrition which they were taking earlier. Enteral route is the most useful, whether the patient is 5% or the patient is 80%. So initially, although the patient was nil only, but as soon as the intestinal function has recovered, the patient has to be started on oral diet and the adequate nutritional support, which will make a difference between life and death of the major burn patient. Because no amount of IV fluid therapy, no amount of parenteral nutrition can really replace the oral diet. In this scenario, we do sometimes add anabolic steroids, maybe based on every weekly or 2 weekly basis to preserve the nitrogen. Now, last thing is systemic antibiotics. Whenever we see a patient of even 2% burn seen by the general practitioner outside, we find that the patient is started on major antibiotics, even injectable antibiotics. But for smaller burns, which are being treated on OPD basis, no antibiotics are required initially. Oral antibiotics are given only after several days if we find that the wound has got infected. For larger burns which are admitted, even in them, we do not give any antibiotic systematically for first initial 5 to 6 days. Only when we find that the patient is showing signs of septicemia, then only we start systemic antibiotics, and that too based on culture sensitivity report and the signs and symptoms, and whether the patient is showing symptoms of impending sepsis. Now, various drug classes are available, so I will not go into the details of all these antibiotics, but in general, for major burns of 40% and above, we do not give one antibiotic. We usually give 2 antibiotics which the bacteria are sensitive to. Usual pathogens, Staphylococcus, MRSA, and Enterococcus, vancomycin-resistant Enterococci, Pseudomonas, E. coli, and Klebsiella. These are Proteus, these are the bacteria, but nowadays this Acinetobacter is also coming up, and this may be even not sensitive to any of our drugs which we have got. As I've told you earlier, after 3 weeks or more, fungi may also jump into our scenario, and they may also require treatment if they show signs of fungal sepsis. Now, once the patient is healed completely, all these patients are to be protected from sunlight. All these burnt areas are to be protected from sunlight, because these healed areas are highly sensitive to the ultraviolet sunlight. So they are given various forms of treatment by me. Use of sunscreen lotions is one of them, but I tend to avoid them. I use items which are physical, like a cap, an umbrella, not going outside during the day hours. If a child is studying in nursery class or first standard, I tell them to take the child off the school for 3-4 months till the color returns to normal. If the patient cannot stop his job, naturally I tell them to go to the job early when the sun has not risen and come back after the sun has set, or he can use an umbrella. So all types of measures are advised, and he should always use full sleeves clothes. He should always use full sleeves, full length dress in the lower limbs also. Then he can wear gloves, he can wear socks. All these types of measures are taken. But small children, maybe who will not listen to us if they go to school, it is better to take them away from the school for a few months. Nothing will happen. We know nothing will happen to their studies if they don't go to school for 2 months. But if they become dark, if the area becomes hyperpigmented, this area will remain hyperpigmented for the whole of his life. This is normal skin. This cannot be converted into hypopigmented skin, which is similar to his other skin. Another thing which we advise them is bland oils and moisturizing creams. Normally, most of the times I advise them to massage the area with bland oils in the form of coconut oil. Why I advise coconut oil? Because it is cheap, available everywhere, and patient also knows what it is. I tend to advise moisturizing creams, especially if the areas are very large. If it is a very small area, 1%, 0.5%, I can advise them moisturizing creams. Simple moisturizing creams which are available in the market, which the patient uses during winter. Now, why do we massage? Apart from the reason that the massage alters the scar favorably, one of the problem which is there is that this skin which has just healed, or even the grafts which I have applied, they are dry. So this area which dry, they tend to crack as our skin tends to crack in the winter season. So it has to be lubricated. The grafts will never get return of the sebaceous glands, hair follicles. So they have to be lubricated for whole of the life. But the burnt areas, they will develop proper glands in over a period of few months, and then they will not need massage with blend oils. Now, another thing which these patients complain is pruritus. There's a lot of itching. Again, this itching is because of the dryness of the skin. So the blend oils, which I advise them, it is treatment of the itching also. Plus, I tell them not to keep the nails long, not to cause infection by itching the local healed wound. It is better if they do massage over the shirt or the pant, over the area, burnt area, and alleviate his itching. But if the patient is still having lot of trouble, I can prescribe cetirizine or phenyramine like drugs, especially at bedtime. Now, what are the causes of death in these patients? Once the patient comes to me, he can die of hypovolemic shock. I have told you about the hemorrhagic ulcers, curling ulcers, asphyxia, inhalation injury, renal failure, toxemia and septicemia. The electrical burn patient, they can get electrocuted right on the spot due to ventricular fibrillation and or fall from a higher height. They can sustain head injuries and other fractures and they can die. But the patients who are extensive burns, apart from septicemia, they are admitted for months together in the hospital. And if the nutrition is not looked after properly, they can die of cachexia, anemia, and hypoproteinemia. Tetanus, I have already told you that they can also die of that. And so we have given them tetanus toxoid. Most important predictor of mortality in burn patients is total body surface area burned and the percentage of full thickness burn and the smoke inhalation injury. Other major predictors are severity and number of other comorbid illnesses and injuries, whether there was any pre-existing malnutrition or whether what are the post-operative burn complications. And I already told you that pediatric burn patients and geriatric burn patients, they tolerate burns poorly as compared to young adults. Thank you. Thank you very much.
Thank you, Dr. Goyal, for such an elaborate, giving us the entire picture right from, the scene, how it happens, how burns may happen and how careless we are at times and how to manage the severe burns cases. I think there are one or two questions in the chat box. Meanwhile, they are also writing their queries in the chat box. Could you explain the, how to manage first degree or partial degree minor do's and don'ts for that,
Yes, madam, the first degree burns, I told they are epidermal burns only. They never come to me. I do not treat them because the patient knows what is the cause and the cause is sunburn. So when you visit beaches, when you visit hill stations, you know that everybody knows that this burnt area on the nose or the face is actually sunburn and nothing is required for that. You can, if you want, you can apply blend creams because there is some amount of itching also. And you may apply a little orally also, you may take something antihistaminics for itching. But most of the times they are so mild and the time of healing is 3 to 5 days only. So they do not really require much. It is the partial thickness burns, which are especially the superficial dermal burns, which heal in 3 weeks time. And they can be treated if they are lesser percentage on the OPD basis, less than 15%. They can be treated by practically all the general practitioners also. And they do not require much treatment other than the dressing part, other than the tetanus toxoid, which everybody knows that tetanus toxoid has to be given to any wound. So they are to be dressed. I've told you the dressing method. And if the biggest thing which you have to take care of in dressing is that it should be a sterile dressing. So first of all, the wound, which most of the times is contaminated when he comes to us, it is to be cleaned with Savlon solutions, soap solutions, and then washed with saline solution, saline water also. And finally, this has to be dabbed dry. Over this, if I find that supposing the area is, to me, appears is very neat and clean, I may not apply even a topical ointment. Especially if I do the burn dressings, I never apply. But I will tell the general practitioner to apply at least soframycin or betadine, because these things are eye soothers for the patient. When I do not apply anything, patient may tolerate me because I am a very, very big surgeon. But if a general practitioner does not apply, the patient will not be satisfied. So it is better for him to apply something for the patient's eyes and for the comfort of the patient. So for that, I will say he can use just betadine, which does not show any resistance. Even soframycin causes resistance. So he can use a little bit of betadine, and over that he should apply a non-stick gauze, then go multiple layers of sterile gauze, sterile cotton pads and bandages. These bandages are changed every alternate day initially, but we have to see that if the patient starts fever, he starts pain, unusual pain, he starts more of a foul smell, then the wound, it means showing signs of infection. So we may have to do the dressing every day also. And within 2 to 3 weeks, I expect they would heal. Another thing about blisters is there that most of the patients,
I was about to ask
most of the patients are afraid of blisters. Most of the patients, when I tell them to pour water, they are afraid of pouring water. Let me tell the patients that when the patient tell me on phone that they have got blisters, I tell them it is a happy situation, because blisters forms only on superficial burns. If they are deep dermal burns, if they are full thickness burns, blisters will not form. So when they pour water on a burn injury and it immediately cools the area, naturally the wound is superficial. It cannot proceed to the deep dermal area or the full thickness. Naturally, it is bound to develop blister. So it is a happy situation. So I tell them blister is a good sign. Blister is a good thing. Blister means that it will heal in 15 days or even less than that. So we should put water on the burn. Similarly, for chemical burns also, our principle is not to neutralize. Our principle is to dilute. Many times, children come to us from schools. The teacher, chemistry teacher, he says that after an acid experiment, he's trying to neutralize it by putting alkali over that. Alkali burns are more dangerous than acid burns. Plus, I always tell them, my skin is not your laboratory. I will not let you experiment titration of acid alkali. I don't have litmus paper. So if you unfortunately put a little more alkali, would you like to put it, neutralize it by more acid? Then it will be just like, I call it as Billy Bandar. Billy Bandar. Billy Bandar story everybody knows, that the two cats went to a monkey to divide the small chapati. He was dividing into two halves and ultimately he ate away everything. So if you go on putting acid and alkali one after the other, ultimately the whole of the skin will go, the deeper bones will also go. So alkali burns are very dangerous because they cause liquefaction necrosis of the fat and they go into the circulation. It is better that if the acid burn remains acid burn, because it forms eschar and it cannot penetrate. Once it forms eschar, it cannot penetrate. So the best treatment is neutralization by the acid only. The second thing which I tell for the chemical burns is that if the patient is working in a factory, then it is the responsibility of the factory malik, owner, and the supervisor to list the name of the chemicals which are being used or produced and what are their antidotes. Many times I've seen the patient comes to us with his companions who bring the bottle of that chemical which is brought to us, which the chemical was being used by the injured victim. So that I cannot remember all the antidotes available. So the moment the victim or his colleagues show me that this was the chemical, I can immediately see what is the antidote. For few chemicals, I know what is the antidote, but I cannot know. So, and even the factory workers should know what is the antidote. That should also be available in the factory. And they should also know. The supervisor should know what to do. The colleagues should know. Everybody should know. The third thing which I tell about the first aid is, then for electrical burns, you should always be careful that you should not become the victim. So if a patient is getting electrocuted, he should be disconnected. Either the electrical connection should be switched off or he should be disconnected using some non-conductor like wood or plastic. But many times we find that two people have got burnt electrocuted, because the next person jumped to save him and the third person jumped to save him, and ultimately the three people got electrocuted instead of one. Then another thing which I have already told you about radiation burn is that we are seeing practically no radiation burns nowadays, because our machines are now so advanced that they are skin sparing machines, and they can really point out exact depth which is involved. And so the number of radiation burns are coming less and less, other than you can say in nuclear disasters. So
Sir, I think you have mentioned this, but still there is a query. If there are blisters, should it be pricked or should it
Yes.
be left alone?
Yes, this is also a very important question, whether we should prick or not. See, the blister fluid is always sterile. Blister is, what is a blister? Blister means it is intact epidermis and underlying dermis is burnt. So that means if the dermis is burnt and it is not full thickness, definitely, because there is a blister, so there are signs of inflammation, and one of the signs of inflammation is oozing. So this blister has formed because of oozing. And in areas where the blister broke away, there will be oozing which will come into your dressing or in your clothes. But when the blister the epidermis is intact, it will form a blister. So there is no need of pricking or removing the blister cover, because unless you prick it, it will not get infected. Unless you de-roof it, it will not get infected. But one problem is always there: how to keep the blister intact. If the blister is very large, maybe say 1 to 5 centimeter or even more, naturally it will not remain intact for a period of 7, 8, 10 days when the wound is likely to heal. So in those cases, it may be aspirated under complete sterile conditions, or it is not a must also. You can simply clean the area, you can put a dressing as if there is no blister. And in the next dressing, if it is still intact, again dress it. If it is by third dressing, fourth dressing, naturally the blister skin which is dead, it breaks of its own, and then it can be removed, because the blister skin is dead. But some people believe that it should be aspirated. Yes, if you are at a risk that the child is small, he will not take care. So before dressing, we may aspirate it also. But aspiration should be done in such a way that we do not introduce infection which was not there. That is the principle. So there is not a must that you should break the blister.
Thank you very much. Are there any questions? You can post it here. He'll be happy to answer. There was one question about maintenance fluids. You mentioned about the resuscitation fluid.
Yes, madam. I have told you that on the first day, the patients are given this formula. But from second day onwards, this formula is not applicable. Number one, from second day onwards, we find that the requirement is actually half of what it was given yesterday. Secondly, by second 24 in second 24 hours, the paralytic alias is also decreasing or has recovered. Thirdly, the requirement is half. Fourthly, we can introduce even colloids if they are available with us. So the fluid requirement is decreased. And moreover, what we find is that on the first day, we have given so much of sodium that on the second day, we need not give sodium at all, and we can just give 5% glucose. On third day onwards, we can give partly 5% glucose, 5% partly glucose saline or even ringer. But from third day onwards, or even from first day onwards, we are monitoring the burn patient's electrolytes also. So it is not mechanical that we have to give only this thing today or only that thing today. On second day, if we find that despite our giving full amount of fluids, the electrolyte sodium is say less, or the potassium is less, because for first 3 days, potassium is not required because of the tissue trauma and release of potassium into circulation. So I do not give potassium for first 3 to 4 days. It is only after that that we require. But sodium, I give after 3 days, second day, after 48 hours. But all these patients, the more extensive the burn patient, the more monitoring is done. Sometimes even thrice, 4 times a day, the electrolytes are measured. So naturally, we have to keep the electrolytes in normal range. We have to keep the urine in normal range. We have to keep the hematocrit in the normal range. So from second day onwards, from third day onwards, especially, I do not tell what the fluid is to be given. I tell the fluid which is to be given is to maintain my parameters within normal limits, which I have told.
Thank you. So there is a question, very often we see in movies that a person with burns, they are covered with blankets or cotton bed sheets. Is this a good, right practice?
Yeah, madam, actually, we say that when the patient is burned, many people say that you cover him with a blanket. Well, I always say blanket is not available even at this time in this room. How will you get the blanket? So it is not, the aim is not to cover by blanket. The aim is to extinguish the fire by whatever means. Secondly, if the patient is burned and you cover it with cover him with blanket because it was available or anything like that, naturally the wound is very hot. So it is not getting time to cool down. So if we have extinguished the fire, it is better it is not covered with anything so that it cools down. Once it cools down, I have also told that because there are areas which are superficial dermal, where the nerve endings are there, they are very sensitive to a draught of air. So by that, the patient will feel pain. So they are to be covered with a piece of cloth. That piece of cloth, I always say, it cannot be sterile. It is not available anywhere except in my ward. So whatever neat and clean piece of cloth, a sheet, bed sheet, or whatever is available, that is should be used to cover the wound so that it does not get contaminated further, as well as the air does not touch the wound, so that the patient is more comfortable as compared to otherwise.
I hope the answer, it is clear to all of us. There is one question about tet globe and egg white and skin of tilapia fish effective for burn.
Pardon, ma'am, could not understand. Could not
There is a
understand.
question: how true is applying egg white and skin of tilapia fish effective for burns?
Madam, skin, egg white, or whatever, I have told you in the first slide, everything under the sun has been applied to the wound. And egg also comes under that. Some people put in atta at home. We say pour water on burns. That is the best first aid at home or anywhere. Even at this place, I have got a glass of water. I have got a bottle of water along with my colleague also. So if there is a burn, if supposing I was drinking tea and it falls on me, immediately I can pour water which is available with me. Instead of telling the colleague sitting here that go and run for a blanket, and run for this thing or that thing. So water is the best thing, and egg, some people even ask whether we should put ice. I have also told if the water is very, very cold, it will either cause damage to the circulation if the area is very small, or if the area is very large and if the large amount of water, cold water, ice cold water is put, naturally the whole patient may go into this hypothermia.
Hypothermia.
And this hypothermia will be very, very important in a neonate, in a small kid. Maybe in an adult, this hypothermia may not be too much because the water may not, too much of cold water may not be available. But the half a bucket is enough to cause hypothermia in a very small kid because he will be covered by whole. So don't run for anything. I always tell that if I tell anybody sitting here to get ice cold water for me, after half an hour the person will come, sir, here is the ice available for you. I have got done so much of efforts to get this ice cold water for you, but by half an hour I have already got burned. So it is better that I use this water and somebody pours this water on me.
I think it answers the question, household injuries, burns that we get from a hot tawa or, iron box. And
wherever there is hot tawa or hot milk or hot thing, naturally water is there, the tub is there, the tap is there. So if my hand touches unfortunately some patila or tawa, I am in the kitchen, I can immediately put my hand into water and I will keep there for 10-15 minutes because this cooling will relieve pain also. It will relieve pain, it will relieve edema, it will bring the temperature lower down to the 37 degrees centigrade or actually to the room temperature, whatever is the room temperature at the movement in the kitchen or whatever place. So it is, we will never advise person to search for a particular thing. We will always advise to search for whatever is available nearby, and water is always available. Similarly, during firecrackers, during Diwali also, we tell everybody to keep a bucket of water in wherever we are cracking the firecrackers, because this bucket will be handy if I get hand burns or face burns. Plus, every fire is small to begin with. So if every house has a bucket of water and small fire starts, I will immediately use that bucket to extinguish it rather than going and filling buckets in my tap. So that is also a principle during that time.
I think you have already addressed this acid burns in school labs,
Yes.
dilution, you have already
Dilution is the
mentioned.
principle. Dilution is the principle, whether it is acid or alkali or whatever, any chemical. Dilution is the principle, although for phosphorus, this is not there, because phosphorus can burn in air also. So this dilution is different thing. And for that, some calcium compounds are also required, but that is not available. We say that first aid is different and my treatment is different. I always say I have never given first aid to any patient in the world in all my career of 40 years, because I cannot give first aid because I am a specialist. How can I give first aid? I will always give specialized care to the patient. First aid is given by the person who is next to the patient. The moment he comes in my hand, he starts receiving proper treatment, specialized treatment. So first is, we have to teach all the children in the schools, in the colleges, to our police wala, to the police personnel, to the fire brigade personnel, what is the first aid? I cannot give first aid because I am not there at the scene of accident. My duty is only to teach everybody, and like what we have taught everybody in the webinar here, the hundreds of people who are attending this, their duty is not to give first aid. Their duty is to teach first aid using media, using schools, so that the children learn what is to be done. And then they will teach even their parents at home that they were taught this thing.
I think this was, initially when I saw your first 2-3 slides, it was quite horrifying to see those pictures. I was quite horrified. But as you went on, it could be as bad, and he rightly puts it that he is there for the management of the wounds, but it begins with the first aid. How do you handle these wounds, because these deformities, these are something which would need series of surgeries to correct them, and maybe you are not able to correct this, so rehabilitation also begins with that.
Yes.
And he has already touched upon that his team comprises of various stakeholders, so do not hesitate and consult the other stakeholders, because rehabilitation, it could be very, very painful for the person victim. So
And his
have,
family. And his family also.
Hanji sir?
It is painful to the family also, madam.
Yes, I know. So I think burns is a very, very big, huge topic, but I think he had touched on all the principles of management. It must have refreshed. These patients can land up at any healthcare setting, at any level of healthcare, anyone, any time of the day. So we should know, how to treat this. I think, and there are a lot of, kudos to you, sir, for taking this session. And I like to thank you on behalf of the participants, and DSPRUD, and Dr. Srivastava is there. He sat through and, the session, over to you, Dr. Srivastava.
Thank you, madam. Thank you.
No, it was extremely, in fact, practical, and a lot of takeaways for everyone, whoever has been logged on, including in fact, I could see our, IT person also nodding, because these are the practical things we all encounter. And we are really grateful to you, sir, for coming and physically conducting. And it was a pleasure to have met you. And we look forward to your continued guidance in strengthening the health system and in percolating this message downward to the every level. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you, sir, for making time to take the session and sharing your valuable knowledge on diagnosis pattern, treatment protocols, pain management, even nutritional importance of the burns and all. I think even I got a more knowledge on this. So thank you so much. Even on behalf of NHSRC and DSPRUD, I thank all the participants, panelists, speakers, and our dear Dr. Jain Srivatsav, sir, for making this session successful. And please note for the participants who is attended the pre and post test sessions, you are going to get the participation certificate through your registered mail IDs. And our next session has been scheduled on 20th May 2023, that is next month, on ADR, that is adverse drug reaction identification and management, and also post-operative care of cataract. All the previous sessions you were asking in the chat what is the link, we have shared the link in the chat box. Even the previous sessions you can go through it and you can access this session after the 4 days. And even pre and post test link is shared. Someone telling that it is not opening, please go and refresh your website or the Google so that you may again recheck it. Thank you one and all for making this
Annapurna, just a minute. This is regarding the post test. We had about 220 pre-test, when we began, and right now we have only 120 or so. Please, we've been putting the post test link in the chat box repeatedly. Open this and do fill it up. Otherwise you will say, we attended the whole session and you didn't get the certificate. This is a requirement. Please do that. And there is also a feedback link in the chat box. Please also fill up that gives us the insights, how this has helped, and it helps us in improving and designing our sessions further. This would be really very useful feedback for us. Post test, please try to fill up the post test as much as possible. अभी काफी कम लोगों ने, I hope you are able to open the link as well. There is no problem. Those of you, we are sorry, some of you could not see the PPT, but I think from our end there was nothing wrong. It was all right. It is the internet connection, which could have hampered your screen and you could not see the presentation. The best thing to do in such a scenario is to log out and re-log in, or check your connectivity if you can connect to a better connection. Okay. I think post-test score, this time we didn't have enough time to discuss. I wanted you to listen to the expert on burn management. So what I have done is I have added answers, feedback. So the moment you submit the post-test, your score and the explanation will be released. I think that should be useful. Regarding the STG, let me just... you will get we'll share a YouTube link also with you. This will be, it will take us at about 4 days time to do this. There was regarding somebody saying that you've answered it correct. There was one question, where there was a problem in feeding the correct answer. I forgot to feed the correct answer. Please read the question carefully and then fill it up. Don't bother about the score. You attempted and did the took the pre-test and post-test. That's more than enough. But I hope you will be able to take home some of the messages and apply this in your day-to-day practice as well. I think you can put once again, Annapurna. You can keep putting the those of you who have done with the post test and the feedback. You can leave. Others, please, you are requested to complete this. Otherwise, you will, complain that you did not get the certificate. Right now, we have got only 133 responses, whereas pre-test was taken by 220 people. Annapurna, please add the uh, feedback link and the post test link again in the chat box.
Yes, ma'am. I have shared post test link, feedback form link, and even the YouTube links.
You can finish it also later, but do submit it. You know, this
And
also
schedule
helps
meeting.
us, this post test also helps us in looking at, which areas were adequately covered, which area wasn't actually, was color, corrected. So maybe when we design or take future sessions, then we can elaborate on those areas where we find that there was not a significant improvement.
Yeah. Ms. Fatima, as this is your first STG webinar, you can access the old webinars through the YouTube link which I have shared already. So the old sessions will be added already in our YouTube channel. You can go through that. And for the certificate, कितने time पे मिल जाता है? You can get it before 3 to 4 working days. Even both YouTube upload and the certificate who has attended pre and post test, you get it before 4 working days.
Annapurna, can you help Bandita? She's repeatedly saying that she's not able to open. I think, uh, how do we help her?
Yeah, I can try with another link. Let me try, ma'am.
Bandita, if you write your phone number here.
Banita,
maybe-
please see with this link. Is it possible to go with this link?
Can you send? She's written her mobile number here. Can you send this link to
Yeah,
her mobile?
sure, ma'am, sure.
Jyoti Sabarwal, you want to say something? Yes, you will get the post-test, the YouTube link. Annapurna, you can put the link again. You can save it. I think if you do search by NHSRC, you can locate this on the YouTube also, even if you don't have the direct link here. $150 responses so far. Others are, I believe, are attempting yet.
Once you subscribe to the YouTube channel, you can get a notification whenever we go on uploading in the channel. Even you can subscribe to that channel once.
Okay. Annapurna, can you mention, DSPRUD also? So some people, their searches through our name also.
DSPRD YouTube channel is not there in the name of
Okay.
DSPRD.
No, is there any, can you do that hashtag or something? Kuch ho sakta hai?
Yes. To do a hashtag, we needed that YouTube link, ma'am. But still, we have done last time. But
हाँ
just
हाँ
whenever
hashtag कर दोगे तो it is easier to locate,
if
these
you attended the
YouTube.
post test and feedback, you can't get the certificate. The feedback is for our improvement. But to get the certificate, pre and post test is mandatory. Yeah, pre and post test questions are same. So that we can know after the attending the pre test what is the score and post test में कितना improvement हुआ है, so that we can observe it. That's why the questions are same. For any queries, you can mail to stg.webinar@nhsrcindia.org, which I have shared in the chat box. Please save this mail ID. For any queries for anything, please mail to this email ID.
I must thank Annapurna for providing all the support, and now I see that she has made a dedicated email ID also for this, so that you can send your queries, follow up, and put loading it on the YouTube. All that it requires a lot of, and then she goes through the pre and post test and see who all have done. Both the sessions, pre and post. Thank you, Annapurna, for providing all the support
Thank you,
here.
ma'am. Snake bite session recording was got crashed. That's why it is unable to add in the YouTube. But we are trying to connect with the sir and make the re-recording of the snake bite session. I think it takes some more time to re-record and upload in the YouTube.
Maybe all these sessions for this year were already aligned and topics were allocated. We have completed 8 sessions. Just 4 more sessions are left, and then next series, then we will begin with the snake bite, and by the time it will be the peak season, also rainy season for snake bite. I think we'll have him back, Dr. Himmat Bavaskar. We'll have him back for the snake bite session. Maybe Annapurna, can we have one extra session?
Need to discuss with the sir.
Just speak to Dr. Srivastava about this. Is there any way, or otherwise people have to wait for another 4 months? We've got responses only from 160 people so far. Okay, can I leave, Annapurna? Annapurna put the link again in the chat box. Somebody
Yes,
saying
ma'am.
that he hasn't got it. Poisoning is yet to be taken. We haven't yet held this session. I think 10th or 11th session is on poisoning.
Yes, ma'am. 11th session is on poisoning. You get it on the month of July.
Okay, I think second last is poisoning.
Yes, ma'am.
Okay.
We
Okay.
have left with post-operative care of cataract for the month of May, and July poisoning, and trauma in the August, and in June I think it's about ANC.
Yes, those of you who have done the post test and if feasible also provide the feedback, you can leave the session. Otherwise, all things are complete.
Certificate you will
166.
get by 5 working days. Within 5 working days, you will get the certificate. Means next within next Friday.
Chaliye, I think I can leave
Yes, ma'am.
Annapurna.
Yes, ma'am. You can get the certificate, the mail stg.webinar@nhsrcindia.org. Through that mail, you can get the certificate. Someone who attended the last and you missed the certificate, you please search with the stg.webinar@nhsrcindia.org email ID, and you can access the certificate if it was sent by us. Okay, thank you all. Thank you for the patience, for being with us from 2:30 to 5:30. It's around 6 o'clock now. Thank you all, and we will meet again on the 20th of May month. Thank you.